A quick review on pulmonary and critical care. We will do it over 2 or 3 sessions. I'm trying to cover the main topics that may be covered in the internal medicine board exam and the upcoming in-service exam in September. This is a part of the blueprint from the internal medicine board website. You can see the pulmonary disease is up to 10% of your exam, and critical care is about another 10%. End of life and palliative care is about 3%. So we are talking about 23% of your exam will be related to pulmonary and critical care. These are the topics we are going to cover. In the first part, we'll talk about basic physiology, pulmonary function test, asthma, COPD, alpha-1 antitrypsin, pulmonary hypertension, cystic fibrosis, bronchiectasis. In the second part, next week, we will talk about other topics left. So a little bit about physiology. If we talk about hypoxemia, the AA gradient, it depends on the age, and the formula to calculate it, there are different formulas. One of them is age divided by 4 plus 4, and roughly this will give you a number between 5 and 15. The simple way of calculation is 150 minus partial pressure of oxygen plus 1.25 partial pressure of carbon dioxide. These values can be obtained from your blood gas. This 150 number came from this equation. Remember, this equation has the barometric pressure, the partial pressure of the water vapor, and the normal FiO2, which is 0.21. So remember, you cannot apply this formula in every single situation. If you have change in altitude, or if the patient is on oxygen, then this can affect your A gradient. If the patient is receiving oxygen, this can increase your A gradient. So for example, your A gradient can increase by 5 to 7 millimeter mercury for every 10% increase in your FiO2. The opposite is right for high altitude, because if you ascend for 1,000 feet, the pressure will decrease by about 24 millimeter mercury. If you apply this number here, this will give you a lower number than 150 because the atmospheric pressure will be lower. So here the normal atmospheric pressure is about 760. If you go to Denver, Colorado, it will be around 520. So this will give you definitely lower number than 150, and this will affect your total AA gradient calculation. When you have a case of hypoxemia, you can calculate your AA gradient, and it helps to classify the cause of hypoxemia. So you may have normal AA gradient in cases of hypoventilation, most commonly on the floor. This will be a patient on pain medication like narcotics. This can suppress his breathing, and this can include CO2 retention and some hypoxemia. But when you calculate your AA gradient in case of hypoventilation, this will be normal. In other situations, when you calculate your AA gradient and it's increased, the cause can be a VQ mismatch or a shunt. The way to differentiate is to give the patient low to moderate flow of oxygen and see the response. If the patient responds and the partial pressure of oxygen increase or improve, this can be a VQ mismatch. If not, you have to think about shunt. Treatment will be, of course, depending on the underlying cause. But if there is a VQ mismatch, you have to adjust oxygen to keep saturation. If there is a shunt, you have to treat the cause of the shunt. For example, if you have intrapulmonary shunt physiology because of collapse of alveoli, you may need to add positive pressure. If you have other causes causing shunt, you have to target that, like AV malformation or other causes. We'll talk a little bit more about shunt. So the shunt can be anatomical shunt or physiological shunt. The anatomical shunt, you have to suspect it, especially if they give you a question with a patient on very high amount of oxygen, because usually the patient will be hypoxic. You will try to correct the shunt with low to moderate amount of FiO2. The patient usually will not respond, and you can go even higher on the oxygen, and the partial pressure of oxygen will not respond to your trial of increasing oxygen. So the usual question giving you a patient on 100% FiO2, usually maybe talking about shunt. The shunt can be anatomic or can be just physiological. Anatomic shunt it includes actual shunting, and you can detect that by ordering 2D echo with a bubble study. You inject the bubble of agitated saline, and it goes to the venous side, goes to the right side of the heart, and you have to watch with the echo for these bubbles when it appears on the left side of the heart. If the shunt is intracardiac, usually these bubbles will appear in the left side of the heart soon, maybe within 1 cardiac beat. If there is a pulmonary shunt, there is time of circulation. The blood has to go through the pulmonary circulation, then the shunt happens and comes back to the heart. So you can see these bubbles on the left side of the heart later, maybe after 3 or even after 5 beats. So it's very important when you order the 2D echo with a bubble study to know when these bubbles appeared on the left side, because it's not positive or negative study. It can be positive, but you need to know how soon the bubbles appear on the left side to know if this shunt is intracardiac or through other abnormality in the lung, like AV malformation, which we can see as a congenital type, or in liver cell failure in advanced stage. You can have hepatopulmonary syndrome with dyspnea and hypoxemia, worse in upright position, give you the term of platypnea for shortness of breath on upright position, orthodeoxia, which is hypoxemia in the upright position. The reason the hypoxemia and shortness of breath becomes worse in the upright position, because this AV malformation tends to be localized to the lower parts of the lung. So when you sit by gravity, there is more flow in the lower parts of the lung, and there is more shunting, and there will be more hypoxemia and more shortness of breath. VQ mismatch, different pathologies can cause VQ mismatch, interstitial lung disease, pulmonary vascular disease, obstructive lung disease. Very rarely to have a diffusion as a cause of increased AA gradient, because it has to be very low, below 30%, and rapid heart rate, so you don't have enough time for diffusion. So the main causes will increase, your AA gradient will be shunt and VQ mismatch. And again, you can differentiate by giving oxygen. If you have shunt, this will not correct. If you have VQ mismatch, this will respond to low to moderate amount of oxygen. This is a patient we received. He was 27-year-old male. He had history of Crohn's disease. He presented with hypoxia, shortness of breath. This was the chest X-ray. I mean, the parenchyma looks clean, but if you can see here, there is maybe a small nodule here, another nodule on the lateral X-ray. Maybe there is something there. If you look more, look under the right copule of the diaphragm. There is something there. And he underwent CT angiography to rule out pulmonary embolism in setting of, we can say, not normal X-ray, but there is no pathology can explain the degree of hypoxemia. So he underwent a CT scan PE protocol, and we can see the AV malformation, big AV malformation here, with it's enhancing, another one here, and we can see it here definitely with the feeding blood vessel. The patient underwent coiling of the AV malformation with improvement of his hypoxemia. So this is an example of shunt due to AV malformation. In this case, the previous one, you have to make sure it's not a part of hereditary hemorrhagic telangiectasia, because these patients can have AV malformation, and these patients with AV malformation, they have higher incidence of a stroke because of this shunt. This is another patient. This is another example of anatomical shunt. We had here for evaluation of possible pulmonary hypertension. She was 37, no past medical history. Doing the right heart cath, her superior vena cava saturation was 95%. She underwent CT angiography with 3D reconstruction, and we can see the left pulmonary vein joining the left innominate vein. So definitely she has a shunt. Partial anomalous pulmonary venous return. The only blood vessel from the left side of the left lung joining the left atrium was here, crossing in front of the descending aorta. And these are different imaging showing the left pulmonary vein joining the left innominate vein. She underwent surgery with improvement of her symptoms. Indication for surgery was enlargement of the right atrium and right ventricle. And there are other indications. We have to see how much shunt she has. And if she has large amount of shunt, this will qualify you for surgery as well, together with symptoms. So when you have a case of hypoxemia, you can look at the carbon dioxide. If carbon dioxide is elevated, this can be a case of hypoventilation. You can look for causes, make sure the patient is not receiving narcotics, or there is nothing affecting the central nervous system causing hypoventilation. If your carbon dioxide is okay and your oxygen is low, you can calculate your A gradient. Your A gradient, if it's low, you can think about shunt and VQ mismatch, and you can give low to moderate amount of oxygen, see the response for oxygen. If it improves, it can identify VQ mismatch. If it doesn't, you can think about shunt. Next, we will talk about oxyhemoglobin dissociation curve. There is what's called 30-60-60-90 rule. If you do your blood gas, the partial pressure of oxygen at 60 millimeter mercury will be almost equal to 90% saturation on your pulse oximeter. If this rule doesn't apply, you have to think about carbon monoxide poisoning or methemoglobinemia. The presentation will be different. In carbon monoxide, you will have pulse oximeter reading falsely elevated because it cannot differentiate between oxyhemoglobin and carboxyhemoglobin, while your blood gas will show low partial pressure of oxygen. In methemoglobinemia, it's the opposite. So you will find your pulse oximeter is low while your blood gas is normal. This is important in case of, you can get a question with carbon monoxide poisoning. They will give you a patient and they will give you history of exposure, and they will give you the pulse oximeter is 98% and the blood gas showing PO2 of 40. So this goes with carbon monoxide poisoning. If it's the opposite, methemoglobinemia case, this is frequently asked because methemoglobinemia can be performed secondary to benzocaine therapy, benzocaine spray, which you use for local anesthesia when you perform bronchoscopy or TEE or AGD. If you give too much spray of benzocaine, that can produce methemoglobinemia, and this can present on the pulse oximeter while you in the endoscopy suite as hypoxemia. And then you will do the blood gas, and the blood gas will be normal. So you will get a case, and the patient is undergoing bronchoscopy. He received benzocaine spray, and you started the procedure. Now the oxygenation is, pulse oximeter give you reading about 80%. There is good air entry. You don't suspect pneumothorax. You do the blood gas, and your PO2 is 200. So in this case, you should consider methemoglobinemia. You should know the treatment for both carbon monoxide poisoning and methemoglobinemia. We will go over it, but just also you should remember the causes of right and left shift for your oxygen dissociation curve. It shows up in the exam on many occasions. If you want to remember it by exercise, you need more oxygen. With exercise, your body temperature rise, your CO2 is produced, lactic acid is produced, so you'll have more acidosis. So if you want to remember it this way, when you exercise, there is right shift for the oxygen dissociation curve. So exercise will do this shift, increased temperature, acidosis, or if you want to remember it by mnemonics, here the C stands for increased CO2, increased acid, which is lactic acid, or acidosis, 2,3 dBg, exercise. All of these causes with the temperature can cause right shift, which will allow easy dissociation. Left shift will be different, which cause difficult dissociation of the oxygen, and this is another mnemonic to remember. If you get a case of carbon monoxide, again your pulse oximeter will show a false elevated reading when compared to your blood gas. You should know the indications for treatment. If you have end organ damage like severe acidosis, cardiac arrest, seizure, or coma, this will be indication for hyperbaric oxygen therapy. If you have carbon monoxide level elevated above 25%, this is another indication. In case of pregnancy, the number goes down to 20%, and the other indication will be fetal distress. So you should remember these indications. Hyperbaric oxygen will decrease your total time or half-life of the carboxyhemoglobin from 90 minutes to about 30 minutes. In cases of methemoglobinemia, the treatment of methylene blue, the treatment can be given if the patient is symptomatic or the level is above 20%. Remember, don't give too much, because giving too much methylene blue can cause hemolysis. Then we will go to pulmonary function test. Pulmonary function test is complicated, more than 2-3 slides, but I will try to give you a simple way just to detect obstruction, restriction, and to answer the question if they require you to identify any of these abnormalities in a setting of lung pathology. So we have the FVC, or the forced vital capacity, and this is the maximum amount of air exhaled after maximum inspiration. We have FEV1, which is the volume of air exhaled during the first second of your FVC. Your total lung capacity is equal to your residual volume plus the vital capacity. Just to remember numbers, remember 80% and 70%. 80% is the number for normal absolute levels. So your total lung capacity should be more than 80%. Your FEV1 should be more 80%. 70% number is for ratio. So FEV1 over FVC should be more than 70%. If it's less than 70%, this can indicate obstruction by Gold criteria. Response to bronchodilator, always remember that you should have increase in FEV1 by 12% and 200 cc. So this is not or. You should qualify for both 200 cc and 12%. To read the pulmonary function test, first you can take a look at the total lung capacity to make sure if there is a restriction or no, and then to the ratio to determine if there is obstruction. Then you can look into the diffusion. So for example, here we have different cases. If we take a look first at the total lung capacity, above 80%, normal, and the DLC was normal, so this is a normal pulmonary function. If you look at the second one, TLC 110, maybe there is some hyperinflation. The ratio is below 70%, so there is some obstruction. The DLCO is decreased, it's below 80%. And the FEV1 is decreased as well. So that can be obstruction. We can see this pattern in a case of emphysema. Third case, TLC, about 100%, normal. There is mild reduction in the ratio here. There is some obstruction. DLCO is normal or a little bit elevated, above 80%. FEV1 is low. This can qualify for obstructed pattern. It can be asthma. Another case, we can look at the TLC 54%, which is reduced. The ratio here is 91%, which is actually increased. Your DLCO is decreased, and your FEV1 is low. This can qualify for restrictive disease. You have decrease in FEV1 and FVC in restrictive disease as well, but the pattern is different. So the total ratio will be increased in restrictive disease while it's decreased in obstructive because of the component which is affected more. In the obstruction, FEV1 affected more, restriction, you may have FVC affected more, and this can give you either low ratio in case of obstructive disease like emphysema, or higher ratio in case of restrictive disease. And the last example here, this is another example. TLC is decreased. This is a little bit increased. DLCO is normal. This can be restrictive, and it can be extrathoracic because DLCO is normal. Again, you have to do the interpretation in clinical setting. You have to associate that with the patient's symptoms, the imaging, pathology, and so on. You have to identify the abnormal pattern of your pulmonary function test curve, or the flow volume loop. So this is a normal one. There is inspiration and expiration. In emphysema, there is scooping or tailing. So this is usually with severe obstruction. In restrictive lung disease, such as fibrosis, it looks like the normal loop, but it's a little bit smaller and shifted. It can give you a different picture. They will call it as witch hat, but basically you should be able to remember this scooping or tailing in case of emphysema with severe obstruction. Different algorithms to do interpretation for pulmonary function test. You can take a look at the spirometry. If you have low FEV1, FVC ratio, think about obstruction. Low FVC or low total lung volume, think about restriction. Normal spirometry, you can think about asthma if there are symptoms consistent with asthma, and you can do what's called methacholine challenge test, and we will touch base on that. Questions. So you have a 68-year-old Hispanic male admitted to the ICU, acute respiratory distress, chest X-ray obtained, bilateral infiltrates, DLCO is elevated. What's the most likely diagnosis? A, B, C, D. What?
D.
So D is the right answer. So DLCO, it can increase with alveolar hemorrhage, it can increase with polycythemia, sometimes with asthma, and this is a quick mnemonic for your obstructive lung disease, including asthma, bronchitis, chronic bronchitis, and emphysema. You have to remember also this other pattern of the flow volume loop, especially these two here. We saw the previous one, the normal flow volume loop has more curve in the inspiratory portion and expiratory portion. When you have this curve with cut off of the inspiratory limb and expiratory limb, you have to think about fixed obstruction. They will give you a patient with repeated intubation, and they will give you that she was diagnosed with severe asthma. Nothing is working. She continues to wheeze despite treatment. And they did pulmonary function test. They will give you numbers, FEV1, FEVC, and they will give you the actual loop. And they will ask you what's the next step or what may be the diagnosis. And in this case, if you see this flow volume loop with cut off of the inspiratory and expiratory limb, you have to think about tracheal stenosis, especially with a repeated history of intubation. So the next step, you may do bronchoscopy to see if there is a real stenosis or no. And if the patient is very symptomatic, you can pursue different kind of treatment other than keep adding steroids and inhaler. The other test question will be the cut off of the inspiratory limb of the flow volume loop. Usually this happens with vocal cord dysfunction. They will give you a similar presentation. Patient with resistant asthma or severe asthma, nothing is working, patient is wheezing, and she is getting multiple courses of steroids with no improvement. And this curve will give you the clue about the diagnosis. There is inspiratory cut off. This goes with vocal cord dysfunction. The third loop, which is expiratory cut off, it can happen with intrathoracic tracheomalacia. Most commonly, they give you a question about tracheal stenosis or vocal cord dysfunction. These numbers here represent the 50% ratio. So you compare this area to this area. In fixed obstruction, these will be equal, and this will give you a number of 1. In case of inspiratory cut off, this area will be longer than this area, and that's why you have a ratio more than 1. Here, the opposite, the ratio will be less than 1, or some books will say less than 0.3%. This is explanation why you have inspiratory cutoff or expiratory cutoff depending on the site of the lesion, intrathoracic versus intrathoracic. It depends on the atmospheric pressure, intrathoracic pressure, and the intra-airway pressure during inspiration and expiration. This will give you an idea about the pathogenesis or how this inspiratory and expiratory cutoff happens. But if you want to remember quickly for the test, extra with inspiration, intra with expiration. So intra with X, extra with N. So that's a way to remember it quickly for your test. So vocal cord dysfunction, a lot of times it's diagnosed as resistant asthma or severe asthma. The diagnosis is difficult. You have to either visualize the vocal cord adduction with laryngoscopy, or you have to find the classic inspiratory cutoff, which is difficult to find, especially if the patient is not having the attack. During the acute attack, you may give some helium-oxygen mixture or CPAP, but basically the treatment is speech therapy, behavioral therapy, and a lot of patients, they have depression. You should target that as well. This is a case we had. A patient presented with multiple history of intubation, resistant asthma, severe asthma, multiple courses of steroids, nothing is helping. The flow volume loop, inspiratory and expiratory cutoff. We thought about stenosis because of multiple intubation, but we did the bronchoscopy, and she had vocal cord dysfunction, but this was atypical. She had inspiratory and expiratory vocal cord dysfunction. So this is during inspiration, the vocal cords are adducted, and this is diagnostic. This is called a posterior glottic shank. So they have preserved posterior glottic shank, which is this opening diamond shape. And during expiration, she still has some adduction, but it's better. And that's why when we did the ratio, it was more than 1 goes with vocal cord dysfunction, plus we saw the vocal cord and she didn't have evidence of stenosis. And when she was breathing, not sure if this is working here. Yeah, I had a video, audio recording for that stridor that she had during breathing, but it was evident that it's coming from the upper airway and not from the lungs. Asthma versus COPD versus overlap syndrome. With asthma, you may have variable airway obstruction. COPD, you have more persistent airway obstruction. And now there is a syndrome with overlap between asthma and COPD can be seen as well. Treatment of asthma is dynamic. You have to assess the patient, determine severity of the asthma, start your treatment, step up or down depending on symptoms. And this is a step-up protocol that you should be familiar with. So step 1, you can use short-acting when needed. Step 2, you can add low-dose inhaled corticosteroid. Step 3, you add long-acting beta-agonist on top of the low-dose inhaled corticosteroids. Step 4, you increase your inhaled corticosteroid to medium to high, plus the LABA. And step 5, you can add other treatments like short courses of steroids or omalizumab, which is anti-IgE. And also you have to focus on avoiding smoking, weight loss, and exercise and such. So this is important, the step-up therapy, and you have to keep it and assess the patient later. If the patient is doing okay, you can do a step down to control the symptoms. Symptom control, you ask about the daytime symptoms, night symptoms, and the frequent use of inhalers, and activity limitation by symptoms. And you can put the patient in one of these categories depending on how many questions they will mark as yes. And then the asthma severity itself, you can classify it as mild and moderate and severe. Mild usually is controlled by step 1 or 2, moderate controlled by step 3, and severe requires step 4 or 5. Now we have bronchial thermoplasty, which can be used in advanced cases. We do a bronchoscopy with thermoplasty of different segment, and this decreases the emergency room visits for these people with frequent exacerbation for asthma, but we have to select the patient carefully for this. I'm trying to advance. Okay. Exercise-induced asthma. You shouldn't avoid exercise even if you have exercise-induced asthma. The treatment usually is prophylactic treatment with short-acting beta-agonists before the exercise. If they ask you in the board, should the patient stop exercise, the answer is no. Long-term control is not required, just short-acting beta-agonists when needed before exercise. If you want to diagnose it, you can do exercise test, and you have to stress the patient to above 85% of the heart rate expected. And in this case, you can measure the FEV1, and you will have about 15% reduction in your FEV1. Reactive airway syndrome is a different thing, which may look like asthma. In the question, they will give you a single exposure to irritant agent. Usually, it can be like chlorine, and then the patient will have frequent episode, which looks like asthma. In this case, you treat it as asthma. You can do methacholine challenge test as well if you are not sure. Asthma and pregnancy. 1/3 of the patients gets better, 1/3 stay the same, 1/3 may do worse. Principles of treatment for pregnant women are the same as for non-pregnant. Actually, asthma attacks carry more risk for the fetus more than the medications we give for asthma control. Even some side effects which were thought to be a side effect of the inhaled steroids or other medications now are thought to be due to the effect of hypoxemia and not the medications. The most studied inhaled corticosteroid is budesonide in case of pregnancy. If you have a patient with asthma recently diagnosed, she's not on an inhaler, it's preferred to start budesonide. If the patient is on different inhaled steroid and her asthma is controlled, symptoms are controlled, you can just continue with the medications she's receiving, even if it's different than budesonide. Samter syndrome, you will have a patient with asthma, nasal allergy, nasal polyps, and history of aspirin allergy, or asthma can be precipitated by aspirin or other non-steroidal drugs. And you can do aspirin desensitization in controlled setting in the ICU, and leukotriene agents can help with the symptoms. Most common 3 causes of chronic cough include asthma and upper airway syndrome, used to be called postnasal drip syndrome, and GERD. So you should target these 3 issues and take good history to make sure what's causing this chronic cough. Asthma can present in a way, the patient just has chronic cough. It's called cough variant asthma, and this can be difficult to diagnose sometimes, and you may need to do a methacholine challenge test. Methacholine challenge test, you give the patient multiple inhalers of escalating doses of methacholine, and you measure your FEV1 after each inhalation and see at what dose your FEV1 will drop by 20%. So in normal individual, you keep giving escalating doses, and the FEV1 will start dropping at certain level, but in asthmatic patients or patients with airway hyperactivity, this drop will happen earlier. And you can take a look at what dose this 20% drop happened, and then you can say if it's normal or mild or moderate or severe. And this can be a helpful way to diagnose cases of asthma which doesn't present with classic picture on the pulmonary function test. Another question: a patient, asthmatic, long-standing, severe asthma, evaluated for new onset fever, fatigue, skin rash, respiratory symptoms. 4 weeks ago, she started taking leukotriene receptor antagonist, tapering off her oral prednisone. Chest X-ray shows bilateral infiltrate. CBC showing leukocytosis with eosinophilia. What's the best next step? A, B, C, D. D. So we will stop the leukotriene receptor antagonist. You have to know that leukotriene modifiers were associated with Churg-Strauss syndrome in patients with asthma, especially when you try to titrate the corticosteroids. It's not known, is it the leukotriene medication is the cause, or just by titrating the steroids you are unmasking the symptoms that were treated with corticosteroid, but that's usually the situation. This is a differential diagnosis for a patient who has wheezing presented with eosinophilia, infiltrate on the X-ray. Make sure it's not infection, and then you have to go through your differential diagnosis. It can be allergic bronchopulmonary aspergillosis. It can complicate asthma, cystic fibrosis. It can cause central bronchiectasis, finger and glove appearance on the CAT scan. IgE level will be very high, above 1,000, and the treatment is steroid. Plus or minus itraconazole can be used as a steroid-sparing agent, but the main treatment is steroid. So we have to think about that. If you have a case of resistant asthma, the patient keeps coming and nothing is working, make sure he's not developing allergic bronchopulmonary aspergillosis. Should be in the differential. Chronic eosinophilic pneumonia, usually middle-aged women, they will have the photographic negative of congestive heart failure, so more peripheral opacities on the chest X-ray. 1/3 they don't have peripheral eosinophilia. The other third differential is Churg-Strauss syndrome. P-ANCA will be positive. They may have glomerulonephritis, very high eosinophils, up to 80% of their white count. Loeffler syndrome, you have to think about medications, if they have a component of allergy to medications, or parasitic infections. In case of Loeffler syndrome, it's called simple pulmonary eosinophilia. Treatment is just stop the offending drug or treat the underlying parasitic infection. Tropical pulmonary eosinophilia will be the last one, but it's not common here. It's secondary to Vishrelia bancrofti, and you will have very high IgE and positive antifilarial antibodies. This is a photographic negative of chronic eosinophilic pneumonia. In heart failure, you will see the opacity more as bat wing appearance. This is more at the periphery, so that's why it's called photographic negative of pulmonary edema. Chronic eosinophilic pneumonia is different from acute eosinophilic pneumonia. Acute eosinophilic pneumonia, you will have a patient who is a smoker, and he will come crashing with hypoxemia and acute picture of illness, and they will not have peripheral eosinophilia. COPD, the classification is still the same, mild, moderate, severe, and very severe, depending on the cutoff points of 80%, 50%, and 30%, but the treatment changed recently, and the classification, so now you have to put your patients in one of these categories, A, B, C, and D, depending on the underlying symptoms and the risk for exacerbation. It may look complicated, but we will dissect it and make it more easy. Patient in group A, they have low risk and less symptoms. So the symptoms here, you go this way, there is more symptoms. You can use two scales, the CAT scale or the MRC scale. Here on that side, this is the exacerbation risk. Here, this is a gold classification. So patients in A, they will have low risk and less symptoms. In B, they will have low risk but more symptoms because we go this way. C, they will have high risk and less symptoms, and D, they will have high risk and more symptoms. It can look complicated, but basically your symptoms increase when you go this way. Exacerbation risk is increasing here, and severity of COPD. This is the MRC scale, but I just wanted you to remember walking slower or to stop, because number 2 is the defining number between mild symptoms and severe symptoms. So basically you can put your patient in one of these categories if you remember 3 questions. First, you have to assess symptoms, then you assess risk. You assess symptoms by asking the patient if he has to stop because of shortness of breath, or if he has to walk slower because of shortness of breath. If he answers yes, he's already above 2. So now you are putting him in the patients with more symptoms, which can be B or D. Then you ask the patient about the risk of exacerbation by asking if the patient had 2 or more exacerbations the last year or 1 single hospitalization. If he answers yes, he is at high risk for exacerbation. And you look at FEV1, if it's lower than 50%, he is high risk. What about if you get low risk here and high risk in the other question? You take the higher risk and you use it for classification. So just the 3 questions will help you to classify A, B, C, D. First, ask about symptoms, if the patient has to stop or if he has to walk slower because of shortness of breath. Second, risk of exacerbation by history of hospitalization last year, history of exacerbation, and finally your FEV1 level. Treatment, we don't use chloride ammonium anymore unless you're taking your course in 1868 or 86. Now we use other inhalers. So you can classify your category of treatment depending on the category of the risk of exacerbation and symptoms. So patients in group A, they can just take short-acting beta agonist. Group B, they may take LABA or LAMA, which is anticholinergic or long-acting beta agonist. Group C, you will add inhaled corticosteroid. Group D, you can add the inhaled corticosteroid with LABA and LAMA. So SAMA, SABA, LAMA, LAMA. Long-acting inhalers, just remember there are new inhalers coming every year. Couple of years ago, we only had salmeterol and formoterol. Other inhalers came out. Also, we had only tiotropium, and other inhalers are coming out, which are long-acting anticholinergic. Just remember the side effects of long-acting anticholinergic with the bad effects with narrow-angle glaucoma, urine retention, and the most common effect is dry mouth, but I want you to remember the side effects, which can be severe, especially if you have a patient with history of glaucoma. Don't combine long-acting and short-acting anticholinergic. Oral treatment. In certain cases, we can use theophylline after we use every other single therapy, and still the patient is symptomatic. You have to be careful because of drug-drug interaction. Narrow therapeutic level can cause seizure, cardiac arrhythmia. You have to monitor your level. You have to remember macrolide and fluoroquinolone, which is the most frequent medications given for COPD patient with exacerbation or infection. They can interact with your theophylline level and increase it. So if you have a patient on theophylline, you admit him to the hospital, you start giving him again fluoroquinolone for pneumonia, you have to remember this, fluoroquinolone may increase your therapeutic level or of theophylline. And the other way, if you start a patient on theophylline in the hospital and the patient is receiving fluoroquinolone and you think your level is therapeutic, you discharge him on the same dose, and he finished the course of fluoroquinolone, the level of the fluoroquinolone will be lower. So you have to remember these drug-drug interaction. Roflumilast is a phosphodiesterase 4 inhibitor. It's called Daliresp. It's oral treatment. It can be used for obese patients with COPD, chronic bronchitis type, not emphysema, and history of frequent exacerbation. It can decrease the weight as well, so it can help with obese patients with COPD who qualify for that treatment. NAC, which is N-acetylcysteine, there is conflicting results. Some trials showed that it decreased the oxidant stress and help with COPD exacerbation. Other trials didn't show benefit. It's not part of the standard of therapy. Surgical treatment, you have lung volume reduction surgery. Now we conducting trials to try to do that by bronchoscopy, by putting endobronchial valve to do some volume reduction. But the main trial was published in New England Journal of Medicine 2003, and it showed benefit for the patients who has baseline low exercise capacity and predominant upper lobe disease. So remember number 20%. If you are above 20% FEV1, DLCO, upper lobe predominance, and you have good exercise capacity, you will not qualify still because of the exercise. You should have low exercise capacity, and you should maximize your rehab before referring the patient for that. Very low number will put you in lung transplantation category, but you have to refer your patient before they hit this number, because once they reach these numbers, they will be high risk for surgery. Improving survival, stopping smoking, and oxygen therapy. You have to remember the indications for oxygen in COPD. The longer you give the oxygen, the better the survival. The two main trials were done. This is combined data from both trials. Better survivor with a longer duration of oxygen. Smoking cessation, you have different categories to choose in between. Just remember the side effect in the board. You shouldn't use Wellbutrin if you have a risk of seizure, and you shouldn't use Chantix or Varenicline if you have a history of depression. Quick difference here, CD4 is the main inflammatory cells in asthma, CD8 in COPD. Asthma is mainly eosinophilic inflammatory condition. COPD is neutrophilic. Subgroup of asthma patients, they may have neutrophilic component, and these are the groups who are not getting the benefit of corticosteroid therapy and inhaled corticosteroids. The reason I highlighted some of these interleukins, some of the new medications for asthma being developed now, trying to target the interleukin 5 and 13, especially for severe asthma. Alpha-1 antitrypsin, just remember, it's more basal predominant, younger age patient. The most severe form is ZZ form. It affects 1 to 3% of your COPD patient. Suspected if you have a patient with a lower age and there is no history of exposure. It's more common in patients with paniculitis and patients with ANCA vasculitis, especially anti-PR3. Treatment, not everyone will get the treatment, but every patient should stop smoking. And if the patient has a low level, which is below 80 milligram per deciliter, and have moderate obstruction on pulmonary function test, and stopped smoker already, then he will qualify for treatment. Quickly on pulmonary hypertension, if you have suggestive symptoms, suggestive echo, you do right heart cath, you look mainly at the pulmonary pressure. The target number we look at is 25 with rest. Sometimes we can do exercise in the cath lab to see if this number with exercise will be above 30. This is the actual number. Most of the studies using the 25 number or 30 with exercise. You should remember your classes from 1 to 5. 1 purely arterial with HIV, connective tissue disease, and venous will be secondary to a left side disease. Class 3 will be secondary to hypoxia, such as an interstitial lung disease, COPD, obstructive sleep apnea. Thrombotic, stage 4. The only thing I want you to remember, don't choose a calcium channel blocker unless they will give you a positive vasoactivity test on the exam. Vasoactivity test to be positive, your pressure should fall below 40 and should fall more than 10 millimeter. Your heart cardiac output shouldn't drop. At least it should be stable or increased. Otherwise, you may harm the patient by adding calcium channel blocker. 50% of the patient who are vasoreactive, in few years they will lose the vasoactivity and they will need a different agent. Warfarin is not the wrong choice if there is no contraindication. We choose a treatment depending on the stage. NEHA class 1, we just observe 2, 3, and 4, we start choosing oral medicine. Till stage 4, you may have drip. Just remember the heart cath. The pressure is 25. If your capillary pulmonary wedge pressure is below 15, this is pure arterial hypertension. If it's above 25, it's secondary to heart failure. In between 15 to 25, you have to calculate transpulmonary gradient, which is basically your mean pulmonary pressure minus your wedge pressure. If you have the number above 12, it means out of proportion of heart failure, so you can still qualify for some therapy based on that. If your number is below 12, then this is proportionate to your heart failure, and we cannot provide specific therapy for pulmonary hypertension. And lastly, these are new medications. I don't think they will show in your in-service or board exam. The only thing I want you to remember is Riosigat is newly approved medication for pulmonary hypertension and thromboembolic pulmonary hypertension. And don't prescribe nitrate or sildenafil with it. Otherwise, you can have serious side effects of hypotension. I think if they cover any of these, this will be the main point. Don't prescribe sildenafil, because sildenafil is most of pulmonary hypertension patients, they may be on sildenafil, and you don't want to start them on this new medication if they are taking that already. I think we are done for today. Last week we started this series of review on pulmonary and critical care. Last time we discussed basic physiology, pulmonary function testing, asthma, COPD, vocal cord dysfunction, and other subtopics in pulmonary. Today we will continue on the second part. I had to split these sessions into 3 parts. The third part will be including parts related to high altitude medicine, sleep, and critical care review. So this is the second part of the pulmonary review. We will start with pulmonary hypertension, because we went through it very quick last time and we didn't have the time to stress on the important points. So previously, pulmonary hypertension used to be classified as primary and secondary. This is the old classification. Now you have to know the type 1, 2, 3, 4, and 5. And you have to know which disease fall in which category. So for example, type 1, it includes the idiopathic pulmonary hypertension, includes pulmonary hypertension secondary to HIV, secondary to connective tissue disease. Porto pulmonary hypertension is included also in this category. Also drug-induced pulmonary hypertension, such as amphetamine, cocaine, it goes under this category. Category number 2 is the venous pulmonary hypertension, which is basically pulmonary hypertension secondary to left-sided heart disease. Type 3 is the disease we see secondary to hypoxemia or secondary to primary lung disease. So patients with advanced severe COPD, advanced fibrosis, or patients with severe sleep apnea, they may have pulmonary hypertension secondary to the hypoxemia. We know the effect of hypoxemia on the pulmonary vasculature, causing vasoconstriction, and this can cause elevation of the pressure. Type 4 is secondary to thromboembolic disease. If the patient had acute PE, later on they may develop pulmonary hypertension, or chronic thromboembolic pulmonary embolism, which is more common in female oral contraceptive pills. There is certain category of patients, young female, they may present later just with dyspnea on exertion without a specific incident of acute pulmonary embolism. And they may have pulmonary hypertension secondary to this chronic thromboembolic disease. Category 5 is miscellaneous. It's important to know these diseases in the workup of pulmonary hypertension because you go through your list and you try to rule in or out every disease. So, for example, HIV testing is part of the workup. Checking the liver function test is part of the workup. History is very important, asking about previous drug abuse, any amphetamine, any cocaine or anorexigenic drugs. You need to get a baseline idea about the pulmonary function and the lung parenchyma. So a lot of times we do high resolution CT with the chest to make sure there is no underlying lung disease. We can get pulmonary function test to make sure there is no underlying severe restrictive or obstructive lung disease, which may be the cause of pulmonary hypertension. If we think the patient also high risk for sleep apnea, we can do sleep studies on these patients. We can do VQ scan as well to rule out chronic thromboembolic disease. So this is important in the workup of a patient with pulmonary hypertension. Usually the patient will have shortness of breath. Someone will do an echo, and which may suggest pulmonary hypertension with a strain on the right side of the heart. The patient will be referred to us. We will do a heart cath to confirm the numbers and measure the pulmonary artery pressure and the wedge pressure. And then once we confirm it with heart cath, the patient has pulmonary hypertension, we will start the workup to determine the cause. Usually the pulmonary hypertension, when we do the right side heart cath, we look at the pulmonary artery pressure above 25 with rest or 30 with exercise. So if we do the heart cath and the pressure of the pulmonary artery is normal, say 23, sometimes we do exercise in the heart cath, so the patient can carry some saline bags or sand bag and do exercise for a few minutes, and we measure the pressure again, making sure it's not increasing with exercise, because this can cause dyspnea with exertion as well. The important point here is about calcium channel blockers, because a lot of people see pulmonary hypertension and think calcium channel blocker, and they just prescribe it and they think it's beneficial for the patient. We do not recommend to prescribe calcium channel blockers without what's called vasoreactivity test. So during the heart cath as well, we usually use inhaled nitric oxide here to make sure the patient is vasoreactive or no. So once we inhale the nitric oxide, the pulmonary artery pressure, to call it positive response, should drop by more than 10 millimeter mercury to a level less than 40 millimeter mercury mean pulmonary arterial pressure, without drop in the cardiac output. So the cardiac output should remain stable or improve. That's why it's detrimental in some people if they get the calcium channel blocker, because this may induce drop in the cardiac output, and this will be bad for the patient. That's why we need to do the vasoreactivity test. Make sure, giving these agents, we can use adenosine, prostacyclin. Here we use the inhaled nitric oxide, and to document if they are vasoreactive or not. If the patient is vasoreactive, they can benefit from calcium channel blocker, but a lot of these patients later on they can lose this vasoreactivity. So if the patient is on calcium channel blocker and later on he was doing okay, improved symptoms, and then symptoms deteriorate, we repeat the heart cath, making sure the numbers didn't go up or the patient didn't lose the positive vasoreactivity test, because then these patients may need other kind of treatment and other groups of medication. Anticoagulation is not the wrong answer, especially if there is no contraindication, and especially in chronic thromboembolic disease or pulmonary hypertension secondary to thromboembolism. Usually for treatment, we decide about the agent of treatment by the New York Heart Association classification. So it's a functional class classification, class 1, 2, 3, or 4. Class 1, usually we just observe the patient. Class 2, you can start adding medicines. Oral medicines, some inhalers we have. Once you progress in classes, you can combine some different classes of different groups of medications. And finally, in class 4 or advanced class 3 stage, you may consider adding IV treatment. There are different classes of medicine, including sildenafil, endothelin receptor antagonist, prostacyclin analogs. And this is a diagram about the heart cath. If you go femoral approach, you will go from the femoral vein, inferior vena cava, right atrium, your catheter will go into the right ventricle, pulmonary artery, and then you reach your pulmonary artery branch, which you can do the wedging of your balloon. So you keep the balloon inflated and you advance it till you see the tracing change, and you know you are in a wedge position, so you can measure the wedge pressure. When you deflate the balloon, then you are measuring the pulmonary artery pressure. When you inflate it and occlude the blood vessel, and you will have a continuous column of blood from the tip of the catheter till the left atrium, this will be your wedge pressure, which is reflecting the left side of the heart or the left atrium. It's important to know that there are a classification of lung zones. Lung zone 1, 2, and 3. We prefer the catheter to be in zone 3. This classification related to if you have a continuous column of blood to the left atrium or no. So we can see in zone 1, the alveolar pressure is higher than the arterial pressure and venous pressure. So it's actually interrupted here. So if you are measuring the pressure, actually you will be measuring the intra-alveolar pressure more, and it will be affecting your reading. This is partial interruption. So the pulmonary artery pressure is higher than the venous, higher than the alveolar pressure, but still the alveolar pressure is higher than the venous pressure. So you can see here there is an effect of the intra-alveolar pressure on your reading. So this is the best position you would like your catheter to be in, where you have continuous column of blood and you'll be measuring data reflecting the left side of the heart. This position the lung is not classified anatomically to zone 1, 2, and 3. It's more of positional classification. The most areas with dependent blood flow. So if you are standing, your zone 3 will be most likely towards the basis. If you lie down, this change depending on the distribution of the blood flow. So it's zone 3 is the most dependent area of your lung, where you have more blood flow and continuous blood flow from the right side of the heart, between the right side and the left side of the heart. The problem with this, you may get a false high reading. Say if the patient is on mechanical ventilation and you have high PEEP pressure and you put your catheter and it's in zone 1, you can be measuring your PEEP, because this is the intra-alveolar pressure applied by the ventilator. So that's why it's important to make sure it's in zone 3. So this is zone 3, where your pulmonary arterial pressure is higher than the venous and alveolar pressure, while the alveolar pressure is less than the venous side. This graph is important, and these numbers are important as well. So we'll do the heart cath. We'll give you the report that the mean pulmonary artery pressure is above 25. So this will qualify for pulmonary hypertension. And we mentioned in the report capillary wedge pressure. So you have to know if your capillary wedge pressure is less than 15, this is pulmonary arterial hypertension. If your capillary wedge pressure is more than 25, this is reflecting a picture of heart failure, which is group 2 with venous pulmonary hypertension secondary to heart disease. In this group, between 15 and 25, we have to calculate what's called transpulmonary gradient. And this is actually the mean pulmonary artery pressure minus the wedge pressure. If the number is more than 12, it means there is a pulmonary hypertension out of proportion of heart failure. So you may still have left-sided heart disease, and on top of that, you may have pulmonary arterial hypertension. If this number is below 12, then it's in proportion to heart failure. In this case, we recommend just management of the left-sided heart failure. Important also to note that you have to pay attention of not only to the wedge pressure and mean pulmonary pressure, but when you get the cath report, you have to look at the pressure of the right atrium. Because say you have a patient, he went for heart cath, and his mean pulmonary artery pressure is 30, or 35, let's say 35, and then the patient is receiving treatment and he's doing worse, and then you repeat the heart cath, and your mean pulmonary arterial pressure on the repeat heart cath is 30. So the first number is 35, the second number is 30. At the first look, you may say, oh, the patient improved, but you didn't look at the right atrial pressure. Maybe the right side of the heart is failing and getting dilated, and that's why the pulmonary artery pressure is going down, but the right side of the heart pressure is going up. So if you have on the first cath right atrial pressure is 5, and now it's 10 on the second heart cath, patient actually may be doing worse, not better. Any questions about the pulmonary hypertension, diagnosis, management, cath? No? Okay. Treatments. Two new medications came out recently, macitentan and riociguat. Riociguat is a new class of medication. It's soluble guanylate cyclase stimulator, and it's approved for both chronic thromboembolic pulmonary hypertension and pulmonary arterial hypertension. Last time I mentioned you have to remember the contraindication because it's contraindicated to give it with nitrates and other treatments that we use commonly for pulmonary hypertension, such as sildenafil. I don't think this will show up on your in-service or your board because it's a new medicine, but if there is any question, I think it's important to know these interactions, because you may be the primary care physician of the patient and he is already on riociguat for pulmonary hypertension, and you are considering adding some nitrate for heart problems, so you should be aware about this contraindication. This is a patient we had. She had hoarseness of voice and dyspnea on exertion, and this is a laryngoscopy picture, and she had left vocal cord paralysis. So the next step, you do CAT scan of the lung to make sure there is no mass causing impairment of the function or invading the left recurrent laryngeal nerve. The CAT scan showed enlarged pulmonary artery, and she underwent right side heart cath, and this is not the systemic pressure, this is the pulmonary artery pressure. So her pulmonary artery pressure was 123/45, and it was so huge, it was causing paralysis of the vocal cord because it was pressing on the left recurrent laryngeal nerve. And this is called Ortner syndrome. Ortner syndrome can happen also when you have enlargement of the left atrium, originally described with patients with rheumatic fever and mitral valve stenosis. When they have enlargement of the left atrium, it can cause compromise of the left recurrent laryngeal nerve, and it can cause hoarseness of voice. She was started on treatment, and she improved, and her pressure is down now. This is another case we had. You have to consider cases of congenital anomalies even in older individual. This is an example, 61-year-old female, past medical history of hypertension, shortness of breath. She had an echo suggested possible pulmonary hypertension. She came, we did heart cath. So this is a normal pathway of a catheter you insert from the inferior vena cava, goes to the right atrium, right ventricle, and to the pulmonary arteries. We should see that path on the X-ray, on the fluoroscopy image. It should be going here and going like this and going to the pulmonary artery. We had this abnormal pathway here. We did right femoral approach. So the first catheter crossed the midline, went up, came down. It went to somewhere. We didn't know where is it, but it's in the tracing. You can tell where it's going. So we saw the tracing that the catheter going into the right atrium and the right ventricle and the pulmonary, but just the pathway was abnormal. She underwent CAT scan with reconstruction, and she had hemiazygous continuation of the inferior vena cava on the left side. She has a left-sided superior vena cava. So you have to be considering also these variants when you evaluate the patient, even if the patient is not in pediatric group. Second, cystic fibrosis. It's a chronic lung disease. Usually can be diagnosed, most of our cases diagnosed during infancy, but again, you can consider it in young adult if they had mild disease and it was not diagnosed before. You have chromosomal abnormality in chromosome 7, and the delta F508, this is the most common genetic abnormality in up to 77% of the patients. And you will have classic picture recurrent meconium ileus in the infancy. You will have pancreatic insufficiency. You may have liver problems, and you may develop diabetes mellitus with the pancreatic insufficiency. And eventually you can develop bronchiectasis and lung disease. Sweat chloride test, if you remember the number, it's above 60. You have to know they use pyrocarbon to induce it. And other causes, it can be false positive in other abnormalities such as hypothyroidism, hypoparathyroidism, mucopolysaccharidosis, severe pancreatitis, severe malnutrition, hypogammaglobulinemia. So you have to consider all of these, and in the criteria for diagnosis, we don't take one criteria. You have to have a clinical picture consistent with that, and then testing. This medicine, El-Kersh, is a new medicine, and only 4% of patients have underlying genetic abnormality. This medicine can work on it. This is the only medicine in cystic fibrosis which target the underlying problem. You know, in the problem in cystic fibrosis, it's mainly transport problem between the sodium and chloride in the respiratory epithelium, and this medicine is targeting this underlying problem, and patients can do very well on it. But again, it's only 4% of the patients, but you can do genetic testing to see which patients will benefit from this. Patients usually colonized with staph, Haemophilus influenza. Later on, they will have colonization with Pseudomonas. The chronic therapy, you give them DNAs and supplementation of pancreatic enzymes. Some of these patients who have chronic colonization of Pseudomonas, you can give inhaled topramycin. These patients also, if you have a cystic fibrosis patient, you will find they may be getting macrolides such as azithromycin 3 times a week for anti-inflammatory effect, and they do better with that. Chronic infection with B. sinusifacia is a contraindication for lung transplant. So if you want to know anything, just remember this medicine, 4% of population may benefit. This is contraindication for lung transplant in most of the centers. It's secondary to a problem of chromosome 7 and sweat chloride test, remember the number 60. Again, diagnosis, don't take just a sweat chloride test and diagnose a patient based on that. You have to have consistent history, clinical picture, genetic testing, and combination of these elements to make the diagnosis of cystic fibrosis. Other causes of bronchiectasis. So this is just a mnemonic to remember the causes. If you have a patient on the floor, you do a CAT scan and the reports say bronchiectasis. So you have to go through a differential diagnosis list, which can include cystic fibrosis, especially if a young adult, allergic bronchopulmonary aspergillosis, so you can order IgE level, post-infectious, which is most common. Think about if the patient has TB, hypogammaglobulinemia, so you can order immunoglobulin level. Other rare syndrome, Cartagner syndrome, if you have situs inversus, you have to think about it. And Meniere-Cohn syndrome. You look at the CAT scan and you compare the internal diameter of the bronchi to the accompanying vessel, and from that you can say if the patient has bronchiectasis or no. This is a patient we had. He came with shortness of breath, fever, cough, sputum production. On the CAT scan, you see dilation of the airway. The trachea is enlarged, airway enlarged. These are bronchiectasis. This is varicose bronchiectasis and cystic bronchiectasis. We did the bronchoscopy, and he has a lot of diverticuli in the airway. And this was a case of Meniere-Cohn syndrome. The patient didn't have cystic fibrosis. Immunoglobulins were normal, and alpha-1 antitrypsin was normal. This is a case of Meniere-Cohn syndrome as an example of bronchiectasis. Interstitial lung disease. This is a broad topic. There is about more than 200 of interstitial lung disease. So this is just trying to have all of these diseases in one table, just for the sake of your exam. And we have different classification for interstitial lung disease. So if you want to classify by the cause, occupational and non-occupational, organic and inorganic causes. So in organic causes, you will have hypersensitivity pneumonitis, stenosis, inorganic asbestosis, silicosis, pneumoconiosis, and periodosis. Non-occupational, you have other things like idiopathic pulmonary fibrosis, collagen, connective tissue disease, LAM, lymphangioliomyomatosis, usually female with pneumothorax, chylus effusion, and it's associated with tuberous sclerosis. Histiocytosis X usually present with pneumothorax. Sarcoidosis, which we see frequently. Alveolar proteinosis is very rare, but you have to know if you know BEM, it's PAS positive, which is periodic acid Schiff stain. You can send for that. If it comes back positive and clinical picture is consistent with that, you can diagnose it, but it's rare. Goldbach syndrome, and you have to have the anti-globulin antibasal membrane antibody, and usually patients present with hemoptysis. Another classification we like is just classified as granulomatous disease versus non-granulomatous disease and known versus unknown causes. It's important to know there are known causes that cause interstitial lung disease, and we try to exclude that in the workup. If a patient comes in the picture consistent with interstitial lung disease, chronic symptoms, restricted pattern on the pulmonary function test most of the time, and restricted volume and some element of fibrosis or ground glass on the CAT scan. So you have to make sure the patient doesn't have chronic aspiration, which can cause basal fibrosis, and the patient can present as interstitial lung disease. You have to ask about history of drugs such as amiodarone, because these patients, they have to be monitored with pulmonary function test if they are receiving amiodarone for long period of time, especially on higher doses. You have to ask about the history, such as history of exposure for hypersensitivity pneumonitis or any organic or inorganic dust exposure. So you have to ask about the occupational exposure, not only now but in the past, and for how long, how was the duration. Still we have unknown causes, but again we have to do through history, physical examination, and serological workup as well to rule out connective tissue disease related interstitial lung disease in the process of workup. Occupational interstitial lung disease, these are some tips for the exam. Hypersensitivity pneumonitis can present as acute, subacute, or chronic. When it presents as chronic, it may look like a pulmonary fibrosis, and it's difficult to just differentiate between it and the pulmonary fibrosis, except for the history. It takes different names depending on the agent the patient exposed to, but all of these are basically hypersensitivity pneumonitis. You'll have the cotton dust disease. If in the typical exam, they will give you a recurrence of symptoms, especially on Monday morning. Asbestos exposure, you have to differentiate between asbestos exposure and asbestosis. So asbestos exposure can cause pleural plaques. You can see it on the CAT scan. And diaphragmatic classification with the sparing of costophrenic angle is important, because you can see pleural calcification in other diseases, and we will show you an image of, for example, tuberculosis can cause that, but you will find the calcification more towards the apex and not towards the diaphragm. Also remember benign asbestos-related pleural effusion, which can be bloody, and it's a benign thing. And you have to remember mesothelioma as well. Asbestosis, on the other hand, you will have more than 10 years of exposure, and it can predispose you to cancer, and usually it affects the basis of the lung and cause fibrosis. Silicosis, upper lung, eggshell calcification. You have to monitor the patient with PPG because they may be predisposed to tuberculosis. Pneumoconiosis and borreliosis will be other categories. With borreliosis, you can do the lymphocyte transformation test. This is a part of the workup, but we rarely see that, and this is mainly can show up on your exam. And borreliosis, it can look like sarcoidosis. Very difficult to differentiate. You will have to do this lymphocytic transformation test to differentiate it. Examples: hypersensitivity pneumonitis, centrilobular pattern. We have to know the pattern of different diseases on the high resolution CT, but this is beyond your exam level. But for example, here we have asbestos related calcification, eggshell calcification because of silicosis, Wagner granulomatosis with cavitation. This is a patient we had presented with shortness of breath, obstruction. We can see the cysts in the lung. She had biopsy, HMB45. If you remember this is lymphangiomyomatosis. These patients can have chylothorax, they can have pneumothorax, and this is the stain, HMB45. Location, just remember the location. Remember, asbestosis affect the base of the lung, other diseases.
And I think it's on their end. There was a few, but I think they left because it's really messy.
Affect the superior parts of the lung.
Well, I'm gonna make that call, but I'll support your decision.
Smoking-related interstitial lung disease, such as Langerhans, cell histocytosis. Smoker will present with pneumothorax usually, and you have to remember for your test, even in internal medicine, the S100 and CD1A. So just remember these two markers for that disease. Most important thing is to stop smoking. Treatment, cladribine can be used, it can help. The other thing is respiratory bronchiolitis associated interstitial lung disease. The only thing I wanted to make clear about it, it's not only a pathological diagnosis, it has to be clinical diagnosis. So the patient should have symptoms consistent with interstitial lung disease, imaging finding consistent with interstitial lung disease, and pulmonary function test finding consistent with that, such as restriction, because if you do biopsy for any patient with COPD, the pathology report will tell you there is respiratory bronchiolitis picture. But this will not put him in the category of interstitial lung disease because this is a smoker's lung, unless you have the supporting evidence of imaging and pulmonary function test. This is a patient we had. He had Langerhans histocytosis, some cysts, and we see small nodules, and this is the S100 stain positive. TPMT testing, some patients with interstitial lung disease, we treat them with azathioprine, but before that you have to do this testing because if the patient has deficiency in that enzyme, he will be or she will be getting the side effects of the medicine because this is the enzyme which metabolize that medicine. Idiopathic pulmonary fibrosis, you will have lung fibrosis, bad CAT scan, chronic symptoms, physical examination. Just remember clubbing and crackles, basal crackles. You can listen to this in up to 85% of the patients with idiopathic pulmonary fibrosis. Usually the distribution is peripheral at the basis. You don't need a biopsy to diagnose IPF. So by ATS criteria, if you have consistent clinical picture, consistent imaging finding, you can do the diagnosis of pulmonary fibrosis also, but you have to rule other things. So usually we do the serology, make sure it's not connective tissue disease related. We take a good history, make sure it's not related to exposure, not related to certain medication. After you rule all of these causes, then you can make the diagnosis of IPF based on the typical clinical picture and typical CAT scan. If biopsy is done, usually the buzzword for diagnosis is fibroplastic foci, temporal heterogeneity, honeycomb change. These areas called honeycomb changes, and it's usually towards the basis. This is a fibroplastic foci which indicate the underlying fibrosis. No treatment, so mainly supportive treatment. We're treating the comorbid conditions, giving oxygen, follow up with pulmonary function test. Don't give this combination because there is increased rate of death. So they did a trial using prednisone, azathioprine, and N-acetylcysteine. It's harmful, not beneficial for the patient. 2 new medications came out in studies, and hopefully they will be approved soon. They can delay the progress of the disease. This medicine is already approved in Europe and being used since 2011. So hopefully it will be approved soon here. This is an example of interstitial lung disease. Patient came with hemoptysis. He had history of scleroderma. We can see the ground glass opacity in both lungs. And we did the serological workup to make sure it's not alveolar hemorrhage. We did sequential lavage. It was negative for hemorrhage. We did the ANCA, antiglomerular basement membrane antibodies. Everything came back negative. He underwent biopsy, and this was non-specific interstitial pneumonitis. So it was basically pneumonitis related to his scleroderma, and we can see the difference here. We can see a lot of cells. So it was a cellular inflammation. When you see a lot of inflammatory cells, it means the patient will respond most likely to treatment with immunosuppressive therapy. He underwent treatment with corticosteroids, and the lung parenchyma cleared, and his symptoms improved. Sarcoidosis, you have different grades on the chest X-ray. The most severe one is grade 4. They don't have to develop in sequence. You have the classic picture of hilar lymphadenopathy. The infiltrate, you can see it follows a bronchovascular bundle, and this can give you a hint that this is a case of sarcoidosis. Non-caseating granuloma, you have to remember that with negative negative fungal stains, because fungal infection can cause you non-caseating granuloma. So the buzzword is non-caseating granuloma in setting of no infection. BAL, remember this ratio, CD4 to CD8, it shows up in the board, and you know the ratio that differentiate between sarcoidosis and hypersensitivity pneumonitis. So in the hypersensitivity pneumonitis, the ratio is less than 1. Sarcoidosis, it's more than 4. Remember, borreliosis, you cannot differentiate it, and it's very difficult to differentiate it from sarcoidosis because it gives a clinical picture similar to it, same radiological pattern, especially with hilar lymphadenopathy. Remember that erythema nodosum, which is usually changes on the lower extremity, on the tibia, tender, painful. This portends better prognosis, and it doesn't need treatment with corticosteroids. Treat severe pulmonary symptoms and extrapulmonary manifestations with corticosteroids, and you have to treat hypercalcemia as well to avoid complications. Two syndromes in sarcoidosis you have to know even in internal medicine. Löfger syndrome, which is basically a combination of erythema nodosum and arthralgia of the ankles and hilar lymphadenopathy. The thing you need to know is treatment is NSAIDs. So they will give you a case with ankle pain, erythema nodosum, hilar lymphadenopathy, and they will give you the option to give immunosuppressive therapy, steroids, NSAIDs. So in this case, you just use NSAIDs. The other syndrome is Hereford syndrome. Usually it's uveitis with parotid enlargement and facial palsy, and you can treat with corticosteroids in this case. But you have to remember these two entities from sarcoidosis. This is a case of sarcoidosis. Sarcoidosis can present with anything. It can affect the liver, can affect the lung. Here in this case, patient came with shortness of breath. Again, CAT scan to make sure there is no cancer. He was non-smoker. There was just this small area here which looked like a mass. We did navigational bronchoscopy, did the biopsy, came back as non-caseating granuloma. This is a non-caseating granuloma. During the bronchoscopy, we saw a couple stone appearance of the airway, which was consistent with sarcoidosis as well. So this was the only involvement, just left vocal cord dysfunction with hoarseness of voice. Patient received treatment, improved, voice came back. So sarcoidosis can present with any picture. This is a picture of erythema nodosum of lower extremity. This is a list of differential diagnosis of erythema nodosum and hilar lymphadenopathy. So this can be sarcoidosis, it can be coccido, it can be histoplasmosis, blasto, tuberculosis, chlamydia, and you have to correlate with the endemic areas. Finally, the TB. When you have TB exposure, you have a chance of infection from the beginning, and most of the cases are contained without progression. So this is the exposure of TB. 70% no infection, 30% you get some sort of infection. This infection will be contained in 95%, and this will be called later as a latent TB. Only 5% will have primary progression of the disease, especially if they have inadequate immunity.
They're having difficulty at the VA.
Just close it. Oh, you just talk here better.
Well, is it on?
Yeah, it's on.
Oh, okay.
This graph here shows you primary progression and secondary reactivation. So when you have the exposure, there is a chance of 5% that you will develop the primary infection in the first year. Later on, you can have late progression. Say you have latent TB infection was contained in your body, and then you have problem with your immunity, then you can have late progression, which is called secondary reactivation. So your chance to develop an infection is 5% in the first year, and then 5% for the rest of your life. HIV is different. So you have 5% after the first year and 5 to 10% each year. So if you have a patient with HIV after 10 years, he has latent TB, there is high chance that after 10 years, almost 100%, they can progress into active tuberculosis. That's why it's important to treat a latent TB. You have to remember these four indications here for positive PPD test above 5. So the PPD test, it's positive depending on the number of millimeter of end duration based on the population you are doing the test in. So if you have more than 5 millimeter, will qualify you for a positive test in HIV infection, close contact with active case, chest X-ray, which is suggestive of tuberculosis, or if you are immunosuppressed. So remember these 4 indications, because in the internal medicine board, they will ask you and will give you a number of 5 millimeter or 15 or 10, and they want you to know, is it a positive test or just you ignore it, which is negative. Remember, 10 millimeter is positive for us, healthcare worker, patients with diabetes, malignancy, silicosis. So if you don't have no risk factor, it's more than 15 millimeter, and then you shouldn't do the test if you don't have risk factor really. But 5 millimeter is high risk, 10 millimeter is for a healthcare worker, will be a positive test. There is another test which is the IGRA, or interferon gamma release, which is a blood test. You don't have to have interpretation, reading numbers, and the ATS and CDC recommending this test in all the indications that the tubercline test is recommended for. Also, they recommend to ignore the BCG vaccine history. So if you have a patient tells you, oh, I have a positive test because I got BCG vaccine, probably it's not because of that, because it wanes after 10 years. The purpose of BCG vaccine in this endemic area, it decreases the incidence of TB meningitis in pediatrics, and usually the effect of BCG vaccine will wane off by almost 10 years. So disregard the history of BCG when interpreting tubercline test results. Treatment, just remember 4.2 and 2.4. This is a busy slide, but they ask you about the treatment. So you start with 4 drugs for 2 months, and then you continue with 2 drugs for 4 months. So total duration of treatment is 6 months. You treat for 2 months, you repeat the culture, you need to see a negative culture in 2 months, and then you will continue. In HIV patients, you can use rifabutin instead of rifampin because of drug-drug interaction. Rifampin will interact with most of the HIV medications. Treatment of pregnancy, you have to know that it's different. So you will omit pyrazinamide from the initial phase. This will come as an MCQ. They will ask you which medication you will not start, which in this case will be pyrazinamide, and you have to know, because you started with a less medicine, then the continuation phase, which is usually 4 months, will be extended to 7 months. So total duration of treatment in a pregnant woman will be a total of 9 months instead of 6 months. Latent TB, you have to know the treatment 9 months of INH. If the patient was in contact with resistant TB case, you will give rifampin for 4 months. So from this page, remember the treatment duration is 6 months. HIV patient, there is a lot of drug-drug interactions. In pregnancy, exclude pyrazinamide from the initial treatment and extend the total duration of treatment to 9 months. You have to follow up the patient, make sure no symptoms of liver problems. You can supplement pyridoxine to avoid peripheral neuropathy. You have to know your side effects of medications, such as ethambutol. It can cause decreased visual acuity. And the multi-drug resistant TB is actually called when the organism is resistant to NIH, INH, and rifampin at least. This is extensive, but the only thing I wanted to show here is if you have a history of infection, especially with cavitation on the initial chest X-ray, and you do your 2-month culture and it's still positive, you should continue your treatment for 9 months instead of 6. The other graph here, this is what's called culture negative TB. If you have a patient presenting with picture typical for tuberculosis, loss of weight, sputum, night sweat, and all cultures are negative and you still clinically suspect this is TB, actually you can start the treatment for 2 months and see the response. If the X-ray improve, clinically the patient improve and culture is still negative, you can just continue treatment for 4 months. And this is called a culture negative TB. It's clinical diagnosis of TB. I don't think they will ask you about that, but they will ask you definitely about the duration of treatment. 6 months, latent TB is 9 months, pregnancy, 9 months, avoid pyrazinamide. Drug-drug interactions in HIV. These are the main important points in treatment of tuberculosis. This is a patient we had. Yeah, go ahead.
If you have active TB, how long treatment person to be able to communicate to another person?
How long contact?
Yeah.
I mean, there is no, usually prolonged contact, but it's difficult to say, and there is no cut number saying that, oh, he will transmit it in a few days, but you have to consider any patient exposed to an active case of TB is high risk, and you have to monitor, and you have to place PPD, and you have to do X-ray. So if you do your X-ray and the X-ray is negative, and you do PPD and it gives you a positive, remember the 4 indication more than 5, then you will treat that patient as a latent TB with that history of exposure and positive PPD. So you have to check to identify the exposure first, find that patient, ask him if there was any recent exposure, contact these people, get a chest X-ray, do a PPD test. If the X-ray is negative, PPD is negative, so there is no risk most likely, but you have to remember in the early exposure, PPD may be falsely negative, so you can repeat it down the road to make sure it's not converting to positive. If the chest X-ray is positive and the patient has TB, you treat as TB. If the PPD is positive, chest X-ray is negative, then you will treat it as latent TB. So you have to pay attention, and this is a very good question, you have to pay attention for the exposure, but how long for transmission, it's a difficult question. Yeah.
And how would you say if this person can't transmit it anymore?
When you have a culture is negative, that's why you do the culture. With the repeat after the treatment. Yeah, so when you have the culture negative, then if positive, then that's why you extend the treatment. And remember, culture negative and positive is different from acid-fast stain, because the bacteria may die and the patient may be still spitting some bacteria. So that's why we say culture positive and negative, not AFB stain. Because you do 2 months, it may be positive, but the culture can be negative. Okay? This is a case of TB. Apical cavity, and this is empyema related to TB, and this is empyema necessitatis, which is the substance break through the skin, the chest wall, I mean, and it's under the skin, and this patient treated, and this is the pre, and this is a post treatment. So this is an example of TB case. Another case, this is old TB. I wanted to make the point of pleural calcification. So this is old TB treated, but it left a manifestation of pleural plaques as calcification. And the reason I'm bringing this X-ray to show you it's more apical, different from asbestosis or asbestos exposure related pleural calcification, which is mainly basal and including the diaphragm. This one here is mainly apical. So not every pleural calcification you will say asbestos exposure. Other causes can cause, like chronic infections such as TB can be a cause. This is non-tuberculous mycobacterial infection. I just want you to remember MAC. It can Mycobacterial avian complex. And the treatment, they asked about this combination of treatment for MAC. Other bacteria, Mycobacterium cancercei, this is the second most non-TB bacteria that can cause infection in the lung after the MAC. And other rapidly growing mycobacteria, I'm not sure if they will give you a question about that, but definitely you have to remember Mycobacterium avian, the treatment for it, and the clinical presentation. Part 3 today will cover some more topics that were not covered in Part 1 and Part 2. First, we'll talk about pneumonia. This is again the review for board exam, in-service exam, so we'll go over more than one topic during the course of this 45 minutes. So pneumonia, you should be familiar with different scores to classify severity of pneumonia. The most simple score is a curve 65 that use confusion, uremia, respiratory rate, low blood sugar, and age. It will help you to classify your patients quickly to know who can be treated as an outpatient, who can be admitted and treated on the floor, and who will need admission to the ICU based on the score. Every point will give you a single digit number, 1 which you can add together and you can find your score. If your score is 3 or more, that score suggested that you should go to the intensive care unit. Other scores like the CPIS and the pneumonia severity index, you should be familiar also with these scores. They are more complicated. Sometimes you may have to have a card to calculate the actual scores, looking at more variables than mentioned in the CARB 65. Also, there is a rule now for procalcitonin to guide you regarding initiating treatment and to stop treatment with clinical improvement and procalcitonin improvement as well. Procalcitonin usually will be high in setting of bacterial infection and not in a setting of viral infection or viral pneumonia. You should be familiar with different types of pneumonia. Hospital acquired, which happens after 48 hours after admission, ventilator associated pneumonia, and we will discuss more because there is a new surveillance system that's suggested now to screen for ventilator associated pneumonia. Again, the 48-hour rule applies with the intubation. Healthcare, you should ask in the history if there is a recent hospitalization to the hospital and when was admission and for how many days the patient was admitted to the hospital. More than 2 days in the previous 90 days will qualify you for HCAB. Also, if there is a history suggestive of extensive exposure to healthcare, like getting chemotherapy, dialysis, and nursing home residents will put you in that category. You don't have to memorize this, but it's coming, so probably you may have heard about it, or you will hear about it soon. This is ventilator-associated events. It's a new surveillance system. The CDC puts this phrase here that this is not a definition. It's used for surveillance, but more and more you will find this being used in the units. Basically, they qualify the events either ventilator-associated condition or infection-related ventilator-associated complication or ventilator-associated pneumonia, which will take at least 8 days to say probable or possible VAB. Because to qualify for VAC, ventilator-associated condition, you have to be on the ventilator with stable conditions regarding PEEP and FiO2 for at least 2 days. And after these 2 days, if there is deterioration in FiO2 by 0.2 or PEEP more than 3, and this has to be continuous for 2 days. So now you are on the ventilator for 4 days. Now you can call it VAC. And subsequently, if you develop temperature, high white count, or low, qualifying you for possible infection, and you started new antibiotics for at least 4 days with the previous oxygen and PEEP change, now you will qualify for IVAC, which is infection-related ventilator-associated complication. So already now we are talking about 8 days. You have to be stable on the ventilator for 2 days, deterioration in FiO2 and PEEP for 2 days, so this is 4 days, and then you will have to be on antibiotic for another 4 days, so this is 8 days, and you have to apply other criteria regarding purine secretion and the number of cell count, and this is different depending if you get it by just BAL by bronchoscopy or just a sputum sample. So this is more complicated, but you will hear about it soon in the intensive care unit. Antibiotic selection for pneumonia, you can treat as an outpatient or inpatient. As we mentioned, we classify patients by CARB score, and this will help guiding, locating our patients either as an outpatient or to the floor or the intensive care unit. Usually in outpatient setting, macrolides or doxycycline will be good. Usually we give azithromycin. You can use 500 milligram in the first day, and that's followed by 250 for another 4 days. Outpatient with comorbidity or antibiotic use in the last 3 months, you may use respiratory fluoroquinolones as your agent, or you can combine beta-lactam and macrolide. Inpatient in which you don't suspect resistant organisms such as Pseudomonas or MRSA, you can treat with respiratory fluoroquinolone alone, or you can combine beta-lactam with macrolide just as we use azithromycin plus ceftriaxone will be a good choice. And you try to ask what was the kind of antibiotic the patient was exposed to recently, because you try to use different antibiotic. So if the patient received fluoroquinolone, you may use the beta-lactam azithromycin combination. And if the patient received the other combination, you can use fluoroquinolone, just not to use the same antibiotic within short period of time. If you have risk for Pseudomonas or MRSA, then you can add coverage with anti-Pseudomonal beta-lactam, and you can do the double coverage for pneumonia with the Pseudomonas, meaning that you will have anti-Pseudomonal antibiotic and the fluoroquinolone. And if MRSA is suspected, such as severe necrotizing pneumonia, and the patient has risk for MRSA, positive nasal swab, then you may add vancomycin or Zyvox. Duration of treatment. Now we recommend the minimal duration of treatment as long as the patient is improving clinically, because you will not find improvement in the X-ray soon to guide you with stopping antibiotic. Procalcitonin has increased role now in tapering antibiotic therapy. Minimum of 5 days with good clinical response will be okay, except if you have other complication, meaning that you shouldn't have any necrotizing pneumonia or empyema or lung abscess, and you shouldn't have resistant organisms such as Pseudomonas or MRSA, because these organisms will need more days of treatment. For example, just Pseudomonas pneumonia, you may need 15 days of antibiotic. MRSA pneumonia, you can use anywhere between 7 to 21 days. It depends on the extent of the infection and the clinical course and the response of your patient. We see a lot of patients with Staph aureus bacteremia. You have to make sure they don't have infective endocarditis as a complication. If there is no good visualization of the cardiac valves with transthoracic echo, we may do a TEE to make sure they don't have infective endocarditis. And you can classify the Staph aureus bacteremia into complicated or uncomplicated. Usually in the uncomplicated, you will have a resolution of the bacteremia within 72 hours. You don't have prosthetic devices. You don't have evidence of infective endocarditis by TEE. And then you can use antibiotics for 2 weeks. If you have complicated infection, such as with infective endocarditis, it will make the duration longer. If you are immunosuppressed, if you have persistence of bacteremia beyond 72 hours, you may need 4 weeks. Endocarditis or hematogenous osteomyelitis will increase further the duration up to 6 to 8 weeks. There is a question mark put on the diabetes here because the evidence is not strong for the diabetes, so just keep it in mind. And this algorithm was done mainly for central line related infection, but again we can use these data to treat Staph aureus bacteremia as well, even if it's not associated with central line. Clinical tips and clinical points you should remember in pneumonia. You should have a follow-up chest X-ray to document resolution of pneumonia. Usually within 6 weeks there should be an improvement in the radiological picture, because remember, some of these patients may not have pneumonia and it may be just post-obstructive pneumonia. They may have underlying lung cancer such as adenocarcinoma, which grows slowly and can present as resistant or difficult to treat pneumonia, and the patient will still have the same infiltrate persistent, and they can be diagnosed later with adenocarcinoma of the lung. So it's important to confirm resolution of pneumonia after treatment. The other thing to remember, if you have volume loss on chest X-ray and you're treating pneumonia, that's abnormal. Pneumonia shouldn't cause volume loss. So for example, you will see a patient with infiltrate, right lower lobe or left lower lobe, and you will find there is marked elevation of the diaphragm on that side, which was not there before. So you have to suspect about any lung cancer, if there is any endobronchial obstruction, any post-obstructive pneumonia, because this may be masking underlying lung cancer. Infiltrate on chest X-ray on the presentation, if the patient is very dehydrated, may not be so clear, and in this case, if the clinical picture is going with pneumonia, you can start treatment and repeat X-ray after hydration. You may find the infiltrates becoming more clear. Again, effusion with pneumonia, you have to make sure it's not empyema, and you have to know what are the criteria of empyema. If you find frank pus when you do thoracentesis, that's empyema. Positive culture of the pleural fluid. If you have, you remember these two numbers, the pH and glucose. pH less than 7.2 and glucose less than 60 will qualify you for complicated effusion. This is key points for different organisms that may help you to identify the causative agent on your board. Streptococcus pneumonia, we see it a lot. It's gram-positive, diplococci. Staph aureus, usually they may give you a history of preceding influenza infection. There is tendency for cavitation, cavity formation, abscess formation, and you have to be careful about the MRSA risk. Of course, it's a gram-positive. Klebsiella, the classic example, they will give you a chronic alcohol user, and he has history of aspiration. Carangelis sputum, bulging fissure sign are the classic signs described with Klebsiella pneumonia. We may not see them now, but still these are buzzwords for the boards, especially with the Klebsiella. Pseudomonas, you have to ask about previous history, underlying lung disease to make sure there is no risk for Pseudomonas infection. Of course, it's a gram-negative. It's very common on mechanical ventilation. Haemophilus influenza, Moraxella catarrhalis, usually will be the patient with COPD. They are gram-negative. Mycoplasma, you have to remember the hemolytic anemia, cold agglutinin, and erythema multiformis, and bolus meningitis on ear examination may point to mycoplasma. IgM antibody you can treat with azithromycin. Chlamydia, you have to remember the treatment, doxycycline. Legionella, remember Legionnaire disease. Pneumonia, diarrhea, change of mental status, change in serum chemistry regarding the sodium and phosphorus. Also, you have to know that we order urine Legionella antigen, but it doesn't mean that the patient doesn't have Legionella infection if it comes back negative, because it's only testing for L1 serotype, and this is about 70% of the cases. So you may have Legionella pneumonia in 30% of cases, and you will have negative urine Legionella antigen, because it's only L1 serotype, which is representing only 70% of cases. Chlamydia psittaci, exposure to birds. Tolerances, exposure to rabbits. These are usually the key points in the question. Other organisms, especially in immunosuppressed individual, you have to remember cocci, histo, and blasto. Cocci, C goes with C, usually more in California. You may have skin manifestation. Histoplasmosis, more in this area, Ohio River, Mississippi River. Histoplasma urinary antigen, usually it's a good test if you think there is a risk for this infection. Also, when you look at the CAT scan, you can go with the imaging till the lower sections, which include usually the liver and spleen. And if you find multiple splenic calcifications, that can be a hint about exposure to histoplasma as well. Blasto, this is a picture for blasto. You have to remember with the B, broad-based budding yeast, you may have a skin lesion. The plan of treatment will depend on your immune status and the condition, severity of illness, symptoms. So the range may be you can just observe up to giving strong antifungal such as amphotericin. So you have to know your patient and the underlying immune condition, the symptoms, radiological manifestation, and all of these factors will guide you through either to choose to treat or just monitor, give oral antifungals like itraconazole, or giving strong antifungal such as amphotericin. This is a patient we had. He was an HIV patient presented with cough, chronic. We can see a small cavitation in the left lower lobe, and also there is lymphadenopathy. You can see the arrow, black arrow, subcranial lymph node, and the white arrow, right hilar lymph node. We did EBUS needed aspiration of these lymph nodes, and the patient had lymphatic cryptococcosis. So this was a primary infection with cryptococcal infection with dissemination to the lymph nodes and it caused this manifestation. The patient also had later cryptococcal meningitis, and he was treated and he recovered. So it's important to remember these opportunistic infections, especially with immunosuppression. Other organisms that may be covered in your board, anthrax. You have to remember anthrax is gram-positive. You will use fluoroquinolone for treatment, but it's a gram-positive. You have to remember this. Also, one of the buzzwords is widened mediastinum because of lymphadenopathy associated with inhalational form of anthrax. Treatment usually is combination, not only fluoroquinolone, but I highlighted fluoroquinolone because it was always confusing for me how we use fluoroquinolone, and this, I used to think it's a gram-negative, but it is a gram-positive. You can combine fluoroquinolone with doxycycline and 1 or 2 additional agents for the treatment. Aspergillosis, think about it if you have underlying risk factor, especially prolonged neutropenia. This will put you at a higher risk. There is angio-invasive characteristic of the this infection, so that's why you may have what's called halo sign. The halo sign, you will have solid consolidation in the middle, and around it you will have ground glass area, and hence the name came as the halo sign. Treatment is voriconazole. You have to remember septate hyphae and acute angle branching. So remember the hyphae are narrow and septate, because this will differentiate it from another kind of infection we will talk about in the next slide. Treatment of choice now is voriconazole. So if you have aspergillosis and you have multiple choice question and they put amphotericin and other factors or other treatments, you should use voriconazole as your treatment of choice. This was done already in a study comparing amphotericin with voriconazole, and voriconazole was better. PCP, you have to remember, especially in HIV patient, chest X-ray can look like anything, even normal chest X-ray. Patient can present with only pneumothorax. So if you have a patient with HIV presenting with pneumothorax, you still have to think about PCP because of this cystic lesion may rupture, and this can present just with pneumothorax. You have to remember indication of corticosteroids in setting of PCP in HIV patient, usually severe hypoxemia, PO2 less than 70, or AA gradient more than 35 will qualify you for that steroid treatment. So again, aspergillosis, narrow septated hyphae, because we have a different case here. This is a patient presented with hemoptysis. He had three-in-body appearance in the right lower lobe and some infiltrate. Transbronchial biopsy was done, and this is a picture we have. So this is broad or wide septi, and it's not. There is no septation of the these hyphae, and you have to remember that because aspergillosis is narrow and septated. This is wide and non-septated, and this is mucormycosis. And this was a rare presentation because the patient didn't have underlying problems such as diabetes. Treatment is posiconazole. So aspergillosis, voriconazole. Treatment of mucormycosis is posiconazole. You have to remember these two, and you have to remember the characteristic of the hyphae, narrow versus wide, septated versus non-septated. The patient was treated, and this is a follow-up CAT scan after treatment with clearing of the right lower lobe. He didn't have sinus infection. You have to think about sinus infection as a source of infection, and you have to order CAT scan sinuses to make sure it's not the condition. He didn't have any of that. It's more common in the bone marrow units with and with immunosuppression and with diabetes as well as risk factor. Also, one of the points to be covered is non-infectious pulmonary complication in patients with HIV. This is a good reference. It's a nice article with the classification of the findings you can see in HIV patients. They have high incidence of asthma, emphysema, bronchiectasis. You can classify the complications as those affecting the airway, parenchyma, vasculature. Interstitial lung disease, they can have some of that malignancy as AIDS defining or non-AIDS defining. And vasculature, we know pulmonary hypertension group 1 fall in this category. Remember pneumothorax in HIV, suggestive of underlying PCP. Pleural effusion, you have to know Light's criteria. The numbers 0.5, 0.6, upper 2/3 of the level of LDH in the serum. Remember these numbers. Don't get confused, because you may find different criteria called modified Light criteria, and they will use the upper limit of normal of LDH as 0.45. It's there as well, cholesterol as 45. These are called modified Light criteria. If you remember Light's criteria, just remember the number 0.6, 0.5, and 2/3. Also, we see this a lot if a patient with heart failure and he has been on diuretics. If you do thoracentesis, it may look like exudate, but it's in fact a transudate, and you can use the serum pleural fluid albumin gradient. So this is a gradient, not a ratio. Only transudative pleural effusion with low pH. Anyone knows which type? So you have a transudative effusion by criteria, and the pH is very low, 6. So that will be urinothorax. So if the patient had a previous renal surgery, sometimes there is a leak and it can track into the pleural space. We had 2 cases of urinothorax before. So your fluid will be transudative and your pH will be very low, and you have to know this because you may go into different direction. Because we discussed before, very low pH will suggest complicated effusion, empyema, so you may be going in a different direction. You cannot have empyema with transudative fluid characteristics, so you have to know about the urinothorax. Also, you can order the creatinine level in the fluid and compare it to the serum, and usually you will have a high ratio. Chylothorax will look like a milky whitish fluid, and the triglyceride level will be high, 115. Remember, 3 causes of high amylase in pleural fluid will be pancreatic cause, perforation of the esophagus, lung cancer, especially adenocarcinoma. There is a trick question, but I'm not sure if they will ask you this. If you have a patient who is alcoholic and he presented with that effusion, and you did the thorax, and he has a mass, and you did the thoracentesis, and now you are confused, you don't know amylase is high, is this because of pancreatic cause or lung cancer cause? So the patient has abdominal pain, he has a picture, can look like pancreatitis, and he has lung cancer. So you can order the amylase isoenzyme and you find the difference. So you should find pancreatic subtype or isoenzyme if the cause is pancreatitis. In case of lung cancer, it's salivary type. So the type of amylase can differentiate the cause of the effusion. Is it coming from the pancreas or coming from lung cancer? Lung cancer will be salivary amylase, and pancreatic causes will be from the pancreas. You should be aware about re-expansion pulmonary edema on removal of large amount of fluid. Pneumothorax. Tension pneumothorax, you don't need chest x-ray to diagnose it. You have to treat the patient as soon as possible. You should know about deep sulcus sign in the ICU, because the patient usually is lying supine. In the first picture, it's clear we have pneumothorax on the left side. Here we have pneumothorax on the right side, but you cannot see the pleural. Usually you will see deep sulcus sign if the patient is in the supine position, because the air track down. You have to pay attention to that, because you may have a tension pneumothorax without clear picture of a radiological image like the first picture. You have to know about the lung cancer screening, the age 55 to 74, still smoking or quit smoking within the last 15 years, and it's a low dose CT. There is a lot of talk about this. It should be done only in the centers which have centers having the capabilities of following up the patient and doing multidisciplinary discussions about every case. It's a grade 2B indication. Different kinds of lung cancer with the incidence. You have to be familiar with paraneoplastic syndromes, including hypertrophic pulmonary osteoarthropathy, more in adeno, parathyroid hormone-related peptide, and squamous. They may give you multiple choice question. One of the things with hypercalcemia will be, is it parathyroid hormone-related peptide or parathyroid hormone? So you have to know it's not the parathyroid hormone, it's parathyroid hormone-related peptide. You may have Eaton-Lambert syndrome with small cell. You have to differentiate it from myasthenia gravis. Usually Eaton-Lambert syndrome, the problem will be presynaptic. Myasthenia gravis will be post-synaptic problem. You will have to differentiate with electrical stimulation. You will have a decremental response in myasthenia gravis, while you will have incremental response in small cell cancer. You have to remember there is no surgery for small cell as well. Adenocarcinoma may mimic pneumonia. The tumor is a slow growing tumor in many cases. Bronchoalveolar carcinoma can look like pneumonia. The patient may be young, female, non-smoker. They may complain of bronchorrhea, a lot of secretions, and the test will be salty because of high potassium secretion. PET scan may be negative because the tumor is not that active. It's slowly growing and the metabolic activity is low, so it may give you a false negative PET scan. You don't have to remember that, but the only reason I put it in just to know who is operable stage 1 and 2. Who is unoperable stage 3 and 4. But you should remember certain points that can hint to spread of the cancer. So we can see right laryngeal nerve is recurrent laryngeal nerve is highlighted. So if the patient complains about change of voice, you have to pay attention in setting of lung cancer that there is no invasion for recurrent laryngeal nerve, because this will move your patient from operable to inoperable. Supraclavicular lymph node, you have to pay attention with physical examination to supraclavicular lymph node. If you feel it, you don't need to do bronchoscopy, you don't need to do transthoracic biopsy, you can just do fine needle aspiration of the lymph node, and if it's positive, you already got your diagnosis and the staging, and the patient is already inoperable. If you have malignant pleural effusion, you should tap this effusion before doing biopsy, because again, this will give you the diagnosis and staging, and you will know it's already inoperable tumor. So just remember change of voice and the history taking or examination, supraclavicular lymph node involvement, and presence of effusion in association with lung cancer. When you decide about surgery, 2 and 1.5, these are two numbers. We use a threshold to see if the patient is low risk for pneumonectomy and lobectomy. They will have acceptable quality of life if the FEV1 predicted and DLCO post-surgery is above 40%. Again, PET scan may be negative in some types of adenocarcinoma. This is a summary of the treatment options depending on the stage. If you want to remember one thing, remember stage 1 and 2, you can do surgery. 3 and 4, there is no option for surgery in these patients. Unless you are removing obstruction, maybe by stenting or doing bronchoscopy as a palliative method. Remember Pancoast tumor. This is a patient, 54-year-old female, presented with shoulder pain, right arm weakness, and everybody, she has history of multiple sclerosis. They thought multiple sclerosis is acting up. She received treatment, went back home, and coming back with more weakness, and she had Pancoast tumor. Usually this tumor affects the apex of the lung. Usually they go to orthopedic first with complaint of shoulder pain, and usually the lung cancer is discovered accidentally. They do X-ray of the shoulder and they found a shadow over the lung, and they will do a full chest X-ray. This is usually the scenario for Pancoast tumor. Solitary nodule, if you want to remember one thing, speculated nodules are suspicious. Calcified nodules usually benign. Still can happen in malignancy, but there are certain characteristics that can point to malignant versus benign nodules. If you put your Krauser on your CAT scan, usually you can read the how many Hounsfield unit, and usually if it's less than 15, the negative predictive value is 97%. So it's good to know this. You have to know your location, because if it's very peripheral, you can do transthoracic needle biopsy. If it's central, we can do bronchoscopy. Now it's different because we have more modalities. We have navigational bronchoscopy, which can reach difficult areas that we couldn't reach before. Pulmonary embolism, you have to know what's the indication for TPA. So it's massive pulmonary embolism. And when we say massive, it's not depending on the size of the pulmonary embolism. It depends on the hemodynamic parameters. So if you have persistent hypotension in setting of pulmonary embolism, and persistent hypotension is, the definition is either systolic below 90, or you have a difference more than 40 millimeter mercury from your usual systolic blood pressure. Usually this will qualify you if you don't have a contraindication. Usually you have this question about submassive PE. The patient is hemodynamically stable, but there is strain criteria on the right ventricle, and there is no strong evidence that giving TPA for these patients will help. A recent trial, New England Journal of Medicine, it prevented progression to decompensation, but there was a risk for major hemorrhage in this group. So it's not a standard of care now to give these patients TPA in case of submassive pulmonary embolism. So massive, persistently hypotensive. Submassive is blood pressure is okay, and you have strain criteria of the right ventricle. IVC filter can be recommended if anticoagulation fail, or if the patient develop an event on anticoagulation while being fully anticoagulated, or if the patient cannot tolerate another PE, which may make him hemodynamically unstable and will put him into the massive pulmonary embolism category. Fat embolism, remember, skin changes, dyspnea, confusion. It can happen after accident, long bone fractures, long bone surgery, sickle cell anemia, occlusive crisis, which may affect the bone. That patient presented with ST elevation, and it was pulmonary embolism. He had evidence of GI bleed recently, so he couldn't get TPA. So you have also to pay attention about, for your EKG changes in setting of pulmonary embolism. Another patient presented with hypoxia, shortness of breath. We thought it's a PE, and this is angiogram. The right lung opacified, the left lung almost there is nothing when the catheter is directed to the left lung. Maybe one branch is open. This is 3D reconstruction. The patient underwent surgery to do embolectomy, and it was not PE. It was she had fibrosing mediastinitis, and she had hilar fibrosis, which was occluding the pulmonary artery to the left lung. So you can have similar presentation, and which is difficult to differentiate, but you should know about these entities. High altitude. Usually the main question comes in the board is the use of nifedipine or acetazolamide in setting of acute mountain sickness or high altitude pulmonary edema. You can use either regression formula or inhalation test to see who will qualify for oxygen when they travel in high altitude, because the inhalation test will simulate 8,000 feet, and you can decide if your patient will need more oxygen or will need oxygen at all in the flight. This is just a quick epoch, because sleep still can show on your board. They will not show epochs, of course, but just wanted to make you familiar. We see the rapid waveform. They go into sleep stage. N1, it's slower. They go into N2. We see K complexes, and they have spindles as well, which are these areas with fast waves. And then you go into a deeper stage of sleep, which is N3, slower, and REM stage, which is a dream stage. You will have rapid eye movement, which is a sharp deflection of the eye movement. You don't need to remember that, but what you need to know, restless leg syndrome, know that it can be associated with iron deficiency anemia. Remember, ferritin level below 50 is your threshold to treat. That usually shows up in the board. Narcolepsy, daytime sleepiness. There are different types. You should know there is cataplexy symptoms, which is loss of muscle tone with excitation. It may be present or not, depending on the underlying cause. Modafinil is one of the treatments. Obstructive sleep apnea, the threshold above 5 is abnormal, and the treatment usually CPAP or BiPAP. We don't treat everyone above 5. We treat above 5 if they have comorbid condition. Above 15 usually is the threshold we use to treat the patient if they do not have comorbid condition and if they are not symptomatic, meaning that they don't have excessive daytime sleepiness. It can be central, it can be obstructive. This is a special kind of central apnea, Chinese stock breathing with a patient with CHF. You should know that this puts you at a higher risk for mortality. There is increased mortality in patients with CHF with Chinese stock breathing and central apnea. We can see the patient's stock breathing here. There is no movement. This is the airflow. We can see that crescendo to crescendo pattern. We can see the desaturation. It qualifies for central apnea because this line here representing the effort, and we can see there is no effort here, so this is central apnea, and crescendo to crescendo pattern qualify you for this category. Quickly in critical care, sepsis, early goal-directed therapy. There is a couple of articles which may change the way we look into this protocol. When you bring the patient, you give fluid, antibiotics, pressors if needed, keep MAP, check the CVP, transfusion and dobutamine are challenged now, and together with monitoring of the central venous mixed oxygen saturation. This is the original trial, included 260 patients. The reason I highlighted these 3 points, because there are 2 trials came in New England Journal of Medicine comparing early goal-directed therapy to standard of care, and there was no difference. And the no difference, I wanted you to make sure that it doesn't mean that treating the sepsis early or giving antibiotic early or resuscitating with fluid and pressors is not important. No, it is important, but these 3 things, I think, starting to fall from the protocol now after these trials they came out. We never transfuse patients with hemoglobin of 10 in our unit anyway, so we already not doing this protocol and every single thing in the protocol, including the transfusion. We're using less threshold now, around 7, hemoglobin of 7. This original protocol used hemoglobin of 10. We don't check central venous mixed saturation for every single patient, and using the dobutamine in the same protocol now for every single patient. We depend on lactic acid. We have other methods to monitor the fluid responsiveness, like ultrasound. We have the Visualeo monitor to monitor the pulse wave, and I think that's what's shown in the process trial, which came out including more number of patients, 1,300, and the take-home point from that study that the most important thing is sepsis is early recognition, adequate fluid resuscitation, and early antibiotic therapy. Another trial just came 3 days ago, which is ARISE trial. Again, we know that transfusion probably is not done now at the threshold of 10. We do it at 7, so this didn't make a difference in mortality as well, and using the dobutamine as well. Again, know that the most important thing, early recognition of sepsis, fluid, antibiotics, and you can give the fluid and then a vasopressor therapy, but the bundle originally described in 2001 didn't show a difference in mortality. You can notice that the mortality in these trials now, for example, this trial, the mortality from sepsis 90 days was about 19%. The original mortality in the 2001 paper with goal-directed therapy was around 40%. So in the last 2 decades, there is 1% decrease for every year. There is 1% decrease in mortality resulting from sepsis. So your average mortality now from sepsis came down from mid-40s to 19%. Activated C protein is not used anymore. Nice sugar trial, you have to know your target of blood sugar. Tight control can cause hypoglycemia, so below 180 is okay. Hydrocortisone only used when you have sepsis and your blood pressure, there is persistence of hypotension despite fluid and vasopressor therapy. You have to know your different types of shock and the status of the cardiac index, systemic vascular resistance, cardiogenic, mainly the low cardiac output, distributive shock, which is sepsis is one of these. You have loss of systemic vascular resistance, hypovolemia, you will have low wedge pressure. You may have different kind, which called obstructive shock in case of tension pneumothorax, for example. Acid base, it's difficult to cover the whole acid base balance, but I'll put 2 questions and I'll try to cover it through it. So this is a case 30 minutes before the end of your call. The ER calls you for an admission, 60-year-old male, CHF, diabetes, dyslipidemia, fever, hypotension 5 hours ago. Vitals, blood pressure is low, tachycardic, blood gas, pH is on the lower side, CO2 is on the lower side as well, some hypoxemia. BMP bicarb looks low, some renal insufficiency. So what you will do? Refuse admission, accept admission, accept, and the answer is not A. So we'll have to think about the last 4 answers. You have to know your kind of metabolic acidosis. So we can walk through it. So you have blood gas, metabolic panel. You look at the pH is on the lower side, acidosis. HCO3 is low and carbon dioxide is low, so there is metabolic element because your bicarb is low. So this is metabolic acidosis. You look if there is respiratory compensation or no, and you use Winter's formula. You calculate the expected PCO2, and it is within limits. The expected PCO2 will be 35 plus or minus 2, which is the case here. So there is adequate respiratory compensation. Then you calculate your anion gap. You have to know the formula: sodium minus chloride plus HCO3. Here will be around 10. And you have to pay attention for the albumin, because if you know your anion gap is 12, you think 10 is normal, this is non-anion gap. No, you have to look at your albumin. So your albumin here is 2, your normal albumin is 4. So your normal albumin of 4 will give you expected gap of 12. So albumin of 2 will give you expected gap of 6. So your normal gap will be 6. So 10 is abnormal. So 10 is an anion gap metabolic acidosis. And then you want to know if there is another problem going on with that or no. So you calculate the delta gap, which is the calculated gap minus expected gap. Your calculated is 10, and your expected in this case is 6, not 12. And this will give you a number 4. And then you do your delta bicarb, which will be 6. And then you calculate delta gap minus delta bicarb. 4 minus 6 will be minus 2. As long as it falls in this category between minus 6 and plus 6, this will be pure anion gap metabolic acidosis. I know there are different methods which you can divide, and you see if it's 1 or less than 1 or more than 1 or more than 2. I think this is easier to do minus, and you will get the number because this will be easier during the test. One last thing, so that here the condition will be pure anion gap metabolic acidosis, because your number when you did the delta was falling in this category. Another question on acid base. So, and again, 7 minutes before your end of call, they calls you for another admission. The patient is hypotensive, acidotic, your BNP showing significant renal failure. The patient is HIV with nausea and diarrhea. So what you will do, call the ICU fellow. He's busy. So what you will do, accept the admission and diagnose pure anion gap, or, sorry, the options, pure anion gap metabolic acidosis, or mixed acidosis, anion gap and non-anion gap. Again, we look at the EPG, we look at the BMP. The pH is low, which goes with acidosis. HCO3 is low, which goes with metabolic. You want to make sure the patient has respiratory compensation, or there is a respiratory element, and you calculate again using Winter's formula, and the number will be within range. Your PCO2 is 17, and your calculated one is 18.5. So there is adequate respiratory compensation. Remember your formula again: sodium minus chloride plus HCO3. And your gap will be 19. In this setting, they didn't give you the albumin, so you expect the albumin to be normal, around 5. So your delta gap here is straightforward. 19 minus 12 will give you 7. Delta bicarb, you calculate it, and then you do delta, and here it's minus 10. So minus 10, it's out of the range. It's less than minus 6. So in this case, you will diagnose mixed non-anion gap metabolic acidosis because of the delta and anion gap metabolic acidosis. So the patient has a mixture of these two disorders. Okay, hi guys, we we'll go to part 4 of the pulmonary critical care review. I will start with 2 cases of acid-base disorder that we started to discuss last time, but we had to finish quickly. I will go quickly over them to see how we calculate the anion gap, delta gap, and to look into the complex acid-base disorders and such. The first case, if you remember, this was a case of hypotensive patients coming to the ER. Blood pressure was low, patient was tachycardic. They did blood gas, pH was on the lower side, 7.35, carbon dioxide on the lower side as well, PO2 70. The basic metabolic panel showing some degree of acidosis as well, with low HCO3. And we wanted to see what's the type of acid-base disorder we had. And we had multiple options. I will go through it step by step. So the first thing, we look at the blood gas and the BMB values, and we can see that at the first look we have low pH, 7.35, so that goes with acidosis. And then you look at your bicarb and CO2 to see if this acidosis, is it metabolic or is it respiratory acidosis. And here we see low bicarb and low CO2, so probably this is metabolic acidosis, and the CO2 is low in trying to compensate for the acid-base disorder. Then we're trying to look if there is the respiratory compensation. We think if the CO2 is lower to compensate for the metabolic acidosis, is it adequate compensation or no? And we here can use Winter's formula, and PCO2 equal 1.5 multiplied by HCO3 plus 8 plus or minus 2. And if we calculate that, we will find the number will be 35 plus or minus 2, which is very close to the level of carbon dioxide. So probably there is a respiratory compensation and it is adequate. The quick way to do it, you can look at the last 2 digits of the pH, which is 35 equal to 34, more or less, and that can tell you that there is a respiratory compensation which is adequate. So this is a quick way to do it. It doesn't work for all values. There is a limit. If you start going very low on your pH, this may not work, but Winter's formula will be consistently accurate in this situation. So till now we know there is acidosis, metabolic acidosis, there is adequate respiratory compensation. Whenever you have a case of metabolic acidosis in your board, in your exam, in the ICU, you have to know, is it an anion gap metabolic acidosis or non-anion gap metabolic acidosis? So the next step in any case will be calculating your anion gap. Anion gap, you have to remember the formula, and sodium minus chloride plus HCO3. And if we calculate that through the PMP values here, this number will be 10. In each case, after you calculate your anion gap, you have to see in the question if they give you albumin level or no. If they don't give you the albumin level, you will assume the albumin level is normal, around 4, and you continue. If they give you albumin level, there is a reason they gave you the albumin, and this reason is to use this albumin level and see what's your expected gap. So for example, in this case, 10 in normal individual with albumin of 4, 10 will be considered more or less normal. Your anion gap anywhere between 10 and 12, that will be normal. But in case if you have lower albumin, this number actually can be representing an anion gap. So your normal albumin is 4, and the expected gap with normal albumin is 12. So in this case, we have albumin around 2. So the question will be, what will be your expected normal gap in this situation? And to calculate that easily, you multiply 2 by 12, and then you divide it by 4, and the number will be 6. So for this individual with low albumin, with albumin of 2, your expected normal anion gap should be 6. His anion gap that we calculated is 10. So there is some discrepancy there. And this should help us to calculate the delta gap. Delta gap is the calculated gap, which we calculated here, which is 10, minus the expected gap for that level of albumin, which is 6. So we have a delta gap of 4. The next step will be calculating the delta bicarb, and this will be 24, which is the normal bicarb level, and we will do it minus bicarb, and this will give you number 6. So now you have two numbers, 4 and 6. delta gap, delta bicarb. The next step to see what's the difference between delta gap and delta bicarb. I know in some books they use delta gap divided by delta bicarb, and then you can look at the number 1, 2, between 1 and 2 and decide. I think doing delta gap minus bicarb is easy rather than dividing, especially if you are in a test. I think this can be quicker, but both ways are correct. So if we do the calculation here, delta gap minus delta bicarb, 4 minus 6 equal minus 2. When you do the minus, anywhere between minus 6 and plus 6 is normal. So 0 is normal, meaning that pure anion gap metabolic acidosis will be ranging anywhere from minus 6 to plus 6 or positive 6. And here, so here this is the pure anion gap metabolic acidosis fall here, and if your number here is more than positive 6, and this will indicate that you have associated metabolic alkalosis on top of your anion gap metabolic acidosis. If your number is minus 6, so for example, if this number comes back at minus 8 or minus 9 or minus 10, then this will be indicating associated non-anion gap metabolic acidosis on top of your gap acidosis that you already diagnosed. So the answer here will be pure anion gap metabolic acidosis, because delta gap, delta bicarb was within that range. So remember, first you look at your pH to see is it alkalosis or acidosis. Then you look at your bicarb and carbon dioxide to see is it respiratory or metabolic. In this case, it was acidosis and it is metabolic. So the next step will be calculating your anion gap. When you calculate your anion gap, look if you have albumin level or no. If you have albumin level, try to see if this level is abnormal. Then you have to calculate the expected gap for that level. And after that, you have to calculate delta value. The reason you calculate delta value is to see if it's only a single acid-base disorder, meaning pure anion gap metabolic acidosis, or if you have another problem going on top of this metabolic acidosis. Second question. Another example of acid-base disorder, another patient presenting low blood pressure, tachycardia, fever, looks like sepsis, pH on the lower side, 7.23, carbon dioxide on the lower side as well. We look at the metabolic panel, HCO3 is low, consistent with possible acidosis. Again, the ICU fellow is playing cards, is busy. The main question here is what kind of acidosis or acid-base disorder we have. So again, you look at your blood gas and you look at the metabolic panel. You look at the pH, it's on the lower side, consistent with acidosis. You look at your HCO3 and carbon dioxide, both of them are low, so again, metabolic. Next step, Winter's formula again. If you notice here, this rule may not apply accurately because the pH is lower. So when you use the Winter's formula to calculate the predicted PCO2 here, and you compensate, you will have your level 18.5 plus or minus 2, which is very close to the CO2. So now we know we have metabolic acidosis and we have adequate respiratory compensation. Next step again will be, once we know that we have metabolic acidosis, we will calculate our anion gap. Remember the formula, sodium minus chloride plus HCO3, and the number will be 19. In this question here, there is no albumin level, so you will assume the albumin is normal, and 19 is high even for normal individual, which should be between 10 or to 12. So you will calculate your delta gap, which will be 19 minus 12. 12 is the expected normal gap for normal individual with normal albumin. This number will be 7. Next step will be calculation of delta bicarb. 24 minus HCO3. 24 is the normal level of bicarb, and this number will be 17. Next step will be calculating delta number, and this will be 7 minus 17. This is minus 10. If you remember from the last example, again, we are falling here in this category here, more negative than minus 6. And this means there is associated non-anion gap acidosis. So the answer will be the patient has mixed acid-base disorder, including non-anion gap metabolic acidosis and anion gap metabolic acidosis. So if you remember in the stem of the question, the patient was hypotensive and he has diarrhea. So the diarrhea probably is the cause of non-anion gap metabolic acidosis, and the hypotension and sepsis causing another acid-base disorder on top of that. It's important to calculate the delta-delta gap, especially if you have a case of DKA, for example, and the patient is vomiting. So DKA is expected to cause acidosis, and the vomitings through losing HCl may bring your pH to a normal value. So actually you may have a normal pH and you have two acid-base disorders going on. And if you don't calculate the delta gap and delta-delta, you may think, no, the patient is okay, pH is normal, and you send him home despite having mixed acid-base disorder. For compensation, Winter's formula, you have to remember it, and the other easy way to remember, if you make this table here, this is alphabetic table. If you see the A before the C before the M, so acute, chronic, and then metabolic acidosis or metabolic alkalosis. The first four are the respiratory disorder. Either you have acute respiratory acidosis, acute respiratory alkalosis, chronic respiratory acidosis, chronic respiratory alkalosis. So for every change in PCO2, you will have that change in HCO3, your bicarb, by 1, in this case 2, 3, and 5 for every 10 change. So if you remember this alphabetical, the A, C, M, and then with acidosis comes before the alkalosis, the C comes before the L. Okay? So that will be an easy way to remember. In the last two, these are the primary disorders here. So in metabolic acidosis, you will have bicarb change by 10 for every 10 change in your carbon dioxide. In metabolic alkalosis, you will have bicarb change by 15 for every 10 carbon dioxide change. So if you remember this, you can list the primary disorder alphabetically here, and then the change in HCO3 for every 10 change in carbon dioxide, you can remember 1, 2, 3, 5. 1, 2, 3, 5. So that will be easy for you if you are in a test and you're trying to remember. Just you can list the acid-base disorder alphabetically, and you put 1, 2, 3, 5, and then you can calculate your change. For example, here, if your CO2, your normal CO2 is around 40, if your CO2 is 60, and this is a case of acute respiratory acidosis, so I have the change from 40 to 60 equal 20, which is 2 multiplied by 10, so the change in bicarb will be 2. Clear? Okay. Any questions in the acid-base part? No? Okay. Then the next two slides will talk quickly about some interaction in the ICU between medications or ICU pharmacology. You have to be familiar with certain adverse effects of medication and certain drug-drug interactions. For example, propofol infusion syndrome usually happens if you are using higher doses, usually above 75, and the patient's more prone to that if they are having systemic inflammation like sepsis, receiving pressors such as Levophed, receiving corticosteroids such as, this is every patient with sepsis, inflammation, Levophed, corticosteroid stress dose, and propofol for sedation on higher dose. So if you have a patient and you're starting noticing development of, you're giving enough fluid, everything should be going in the right direction, but despite that you are starting to develop rhabdomyolysis, severe metabolic acidosis, renal failure, hyperkalemia, cardiac failure, you have to think about propofol infusion syndrome. Treatment is supportive, you have to discontinue the propofol and switch to another sedative agent. IV lorazepam, which is Ativan, we use in the ICU. You have to be aware about propylene glycol-induced lactic acidosis. So if you have a patient and you are using Ativan, everything is going in the right direction, patient is recovering, blood pressure is okay, patient is off pressors, and you starting noticing the patient is acidotic and he's developing anion gap metabolic acidosis, you have to think about that as a causative agent. Number 3, not in the ICU, but you can see admission, you get called to admit a patient. Chronic acetaminophen use, usually reported in older female, they can present with high anion gap metabolic acidosis, and you may get called from the ICU to evaluate this patient in the ER, and you go there, lactic acid is high, the patient doesn't look sick, blood pressure is okay, there is no other cause. You have to ask this in the history if she's using the acetaminophen for arthritis or any other reason. You may find this acidosis, and it's because of accumulation of pyroglutamic acid, and it can be measured, but it can take time, and the exact mechanism is unknown, but probably due to glutathione depletion. Also, if you have an HIV patient and the patient is receiving antiretroviral therapy, and don't use midazolam for sedation if the patient is still using. Yes?
Does that Tylenol toxicity, does it respond to like thiamine and...
It's a good question. There are few cases reported about that. It's a good thought because the glutathione has the sulfur moiety, which is in the cysteine, but there is no clear-cut guideline to treat it. Most of the cases is supportive management, just you just continue in it and support and treat any other side effects. And some cases they tried it, but if it's not like a clear-cut to use it or no. But it's a good thought because there is a depletion of your sulfur moiety, and you deplete you replace it. And some cases they tried it for that, yeah. But there is no clear cut to use it. You have to use it. No. Yeah. You ask it, is it only the drip or pushes? Yeah. Ativan is the same. It will have the same component, but probably with the drip you will be getting higher doses other than pushes. But if you require it so frequently with pushing the Ativan every so often, then you may have the same side effect. So it doesn't depend on the route of administration, drip versus pushing. It depends on the cumulative total dose more than the way of administration. So HIV patient, midazolam, if you start him on the midazolam and the patient is still receiving the antiretroviral therapy, you may have drug-drug interaction with prolongation of clearance of midazolam. So in these cases, you will stop the midazolam and wait the patient to wake up, and there will be prolonged action. So you have to be aware about that. Xivox or linezolid can cause lactic acidosis, especially if you are using it large doses, long time. For example, if you have a patient with Staph aureus infection, endocarditis, and you discharge him on oral Xivox, and the patient takes it for weeks, you have to be aware about this side effect. Also, it can cause some problem with the optic nerve in long-term administration. You have to be aware about it. And PRES, posterior reversal encephalopathy syndrome, can result from calcineurin inhibitors such as cyclosporin. So if you have a patient immunocompromised and presenting with PRES-like picture, and the patient is on cyclosporin, you have to be aware about it. Calcium channel blockers, especially diltiazem and tacrolimus or Prograf, you have to be aware about the interaction because you will get a patient, transplant patient, receiving Prograf, goes to the ICU, develop AFib, and you start cardiazem drip, and then you will have issues with your level. In this case, we prefer beta blocker, which does not have this interaction. Another thing you have to know, cis-atracurium, which we use for severe ARDS, for paralysis. Nimbix is the name. The dose is not affected by renal or liver function. So you have to know about that as well. Then we will touch base about mechanical ventilation. Two things. When you ventilate a patient, you targeting normal pH with or baseline pH, carbon dioxide, and you target oxygenation. Looking at the pH and carbon dioxide, they have inversely proportionate relation with the minute ventilation. So the minute ventilation, which is the respiratory rate multiplied by the tidal volume, if you go up on your respiratory rate, your carbon dioxide will go down. If you go up on your tidal volume, your carbon dioxide will go down as well. Oxygenation depends on two things mainly, the FiO2 and PEEP. If you increase your FiO2 and or increasing your PEEP. That will improve your oxygenation. When we do mechanical ventilation, we try to avoid O2 toxicity, so we try to use the minimum oxygen that will keep a safe level of oxygenation. We try to avoid barotrauma, and that's why we try to keep the plateau level within acceptable level, less than 30. The lower your plateau, the better the outcome. Volumetrauma, we try to avoid it by applying minimal tidal volume, 6 ml per kg, and you have to remember it's the ideal body weight which you calculate from the height. It's not the actual patient weight. This is important. And now, not only in ARDS, multiple clinical trials coming out showing better outcome with using lower tidal volume, even if you don't have ARDS. Best PEEP, difficult question, but that's the least amount of PEEP that you can apply and allow safe oxygenation without causing hemodynamic compromise. Different methods you can use to calculate the actual PEEP, including plotting in the volume pressure curve, but this is beyond this lecture. But just broadly speaking, it will be the minimal amount of PEEP that will allow you to have a safe oxygenation with minimum utilization of FiO2 without hemodynamic compromise. Just two things you have to be aware of with mechanical ventilation. If you are doing the ICU rotation, you will frequently hear peak pressure and plateau pressure. So the peak pressure is the maximum pressure we reach inside the airway here during mechanical ventilation. You have to remember it's directly related to resistance and flow. The reason I put the resistance in red, because it's changing, driven by the patient. Flow, it will be you doing vent changes, okay? Plateau pressure, which is measured usually at end inspiration, is actually the distending pressure, which usually distending the small airways and the alveoli. That's why I put this drawing here. Airway is here and the alveoli is here. With the plateau pressure, you do hold at end inspiration to measure your plateau pressure. The plateau is inversely proportionate to compliance. Also, it's related to the tidal volume, but again, the reason I put the compliance here is this is patient-driven. So the next scenarios I will talk about, the nurse will call you and there is a sudden deterioration in the respiratory status of the patient and no one touched the ventilator or did any change. That means probably things happened to the patient. So remember, peak depends on the resistance, plateau depends on the compliance. In this situation, if there is sudden deterioration of the respiratory status, the patient is on mechanical ventilation, and the nurse calls you, there is high peak pressure. What will be your next step? Next step will be measuring plateau to differentiate the causes. If the peak is high in isolation, it has different causes than peak and plateau elevated. So if you go there and you put in the inspiratory hold and your plateau is high, our limit is 30. If you are above 30, we consider it high. So if you go there, peak pressure is very high, plateau pressure is very high, you have to think about compliance issue. Compliance issue meaning anything causing compression of the lung. It can be a pneumothorax, it can be abdominal compartment syndrome, it can be rapid accumulation of pleural effusion if you have malignant effusion accumulating rapidly. So you have to think about things affecting compliance. Pulmonary edema. So if you have a patient who's on hemodialysis and you didn't do dialysis, probably that day of dialysis you may find high peak pressure, high plateau pressure, and the nurse will call you, and probably that patient after he gets dialysis you will find these numbers going down. The other scenario is you go there and you measure the plateau. Plateau is normal, so there is only isolated increase in peak pressure. It's a resistance problem. So you have to make sure there is no kinked tube. The patient is not biting on the endotracheal tube. There is no obstruction in the endotracheal tube. Patient is not wheezing. So probably in this situation you'll do suction for the patient. You will give him some bronchodilator and make sure there is no issues with your tubing system. So these are the two main numbers or values you should remember. Peak and plateau. You have to remember the peak by itself goes in relation with resistance, and plateau is related to compliance. Weaning, you have to have a patient who is hemodynamically stable, alert, can follow commands with stable baseline oxygenation. In this case, also you have to know about rapid shallow breathing index, which is the respiratory rate divided by the tidal volume in liters. And this number is helpful with making decisions, with extubation, but you should not go only with this number in context of the clinical picture of the patient and the situation. We like to see this number below 105. The patients who having this number qualify for a spontaneous breathing trial, and that should be anywhere between 30 minutes and up to 2 hours. Usually we do, there was a study showed no difference between 30 minutes and longer duration. If we have a patient who is very sick and debilitated and have been on the ventilator for longer period, we may do the spontaneous breathing trial for a longer duration. But if it's a straightforward case or drug overdose or recent intubation, few days, just 30 minutes should be equal to longer duration and you don't leave the patient forever on the ventilator doing a spontaneous breathing trial. Otherwise, the patient may get tired, and then you will have a failed spontaneous breathing trial. So don't put the patient on spontaneous breathing trial and go finish all your rounds and come back in the afternoon, and so that shouldn't happen. Also, you have to consider other things like strength of cough, secretion. Secretion is very important. So if the patient has copious secretion, have to be suctioned every hour, probably it's not the time yet to extubate the patient. Question. So 10 minutes after starting mechanical ventilation on assist control mode, 55-year-old male with severe emphysema drops his blood pressure to 110/70. To 90/60, trachea on the midline, breath sounds are distant bilaterally. First intervention, giving fluid, giving levofed, pulling the tube, putting chest tube, remove the patient from the ventilator and ambo bag. Which one? E? Yeah, E is the right answer. This is a case of O2 PEEP. You have to remember this. Some hints here, the patient has COPD. Usually it happened with the COPD, and we can comment about it here. Remember these three scenarios: hypotension or some compromise after you newly intubated the patient. So remember O2 PEEP, secondary to air trapping. This is the flow curve, which is usually on the ventilator. You can tell from the flow curve the patient has O2 PEEP. This line normally should go back to the baseline here. So if the line does not go back to the baseline, this represents the O2 PEEP. And in this case, the patient does not have enough time to exhale. A COPD patient need more prolonged time of expiration to get rid of all of that air. Otherwise, they will keep trapping air, and this will cause O2 PEEP and hemodynamic compromise. In this case, you have to decrease your respiratory rate. The other way to help is increasing respiratory flow. If you increase respiratory flow, the air will be delivered more quickly during inspiration, making the expiratory time longer. So we were rounding with the ICU and a COPD patient having a flow rate of 40. 40 is usually low for COPD patients. So we increase it to 60 and the patient improve. So you have to remember respiratory rate. Don't put very high respiratory rate for patients with COPD, and don't put very low flow on these patients. The other thing is intubation on the right main stem bronchus, and you will have left lung collapse or atelectasis. This will be clear from physical examination, decreased breath sound on that side, or tension, pneumothorax, and they will give you a hint about the trachea is not at the midline or shifted trachea. This question can come targeting a patient with Guillain-Barré syndrome, myasthenia gravis. You have to remember this number. So what are the predicting respiratory parameters that can predict your respiratory failure in this individual? You can remember this rule, 20, 30, 40. So vital FVC, which is forced vital capacity, if it's less than 20 milli per kg, maximum inspiratory pressure less than 30, maximum expiratory pressure less than 40, these can be predicting that the patient is at high risk for respiratory failure and probably need intubation. So remember 20, 30, 40. ARDS, most common causes pneumonia aspiration as local causes, and general causes sepsis. You have to remember the Berlin definition. You have to remember acute onset, bilateral infiltrate, respiratory failure not in proportion with cardiac failure. You have to remember your ratio less than 100, from 100 to 200, 200 to 300, and this help with predicting the outcome and prognosis. The easy way to remember is 234. 234. So 20-something% will be your mortality, 30-something% will be your mortality in the moderate, and then severe in the 40. So remember, mild, moderate, severe, 234. That can help you even with the discussion with the patient family that he has severe ARDS. ARDS by itself puts him at mortality rate of 45%. On top of that, the patient has sepsis, and that can be helpful, especially in the discussion. The only problem about that, it's on PEEP of 5. We don't have any RDS patient with PEEP of 5. But the prior definition did not have even PEEP of 5. So this is an improvement. Maybe the next definition they will add a combination of PO2, FiO2 with the PEEP value to make it more accurate. Because it's not the same if a patient having 100 to 200 range on PEEP of 8, 10. And then what about if you change the PEEP to 15 and he improved to the mild? Which one you will use? So it depends on other factors as well. You have to remember two things about ARDS. Two things came out last year: the prone positioning and high frequency ventilation. So prone positioning, if you find it in your question, it's a good thing. Now it's considered to decrease mortality, so you can use it. High frequency ventilation didn't show improvement, and we will go quickly over the trial. ProZeva trial is a prone positioning, and it showed decreased mortality, but in severe ARDS in 1 month and in 90 days, we can see here in supine position there is atelectasis of the dependent parts of the lung. You prone the patient, there is better oxygenation. But remember, severe ARDS, not every case of ARDS. This is beyond the topic, but this is one of the explanations why when you prone the patient, they have better oxygenation. They have homogeneous distribution of the air here. This is in supine position. This is in prone position. Here, the lung height. So here, you can see this is the gas-tissue ratio. One of the explanations is you have two factors, the shape matching effect and the gravity effect. In case of supine position, the shape matching effect and the gravity effect work in the same direction, causing more atelectasis of the lower alveoli and relatively hyperexpansion of the apical one. When you put the patient upside down, these two forces act in opposite direction, and this leads to homogeneous distribution of the air inside the lung, among other factors which can explain better oxygenation in ARDS. You don't have to remember this table, but why the only one trial, which is the latest trial of prone positioning, showed benefit, and there was multiple trials did not show benefits. First, these cases were very severe. If you look at the ratio here of PO2 FiO2 ratio, this is the group with the lowest, so that's why the severe ARDS will get the benefit. Number two, they did it for appropriate time, more than like 16 hours per day. Number three, if you look at some other trials, they did not use protective mechanical ventilation in these two trials, and even here when they said, yes, we used protective mechanical ventilation, the tidal volume was 10 milli per kg, 8 milli per kg, but here, in this trial, we use the 6 milli per kg. So there are multiple things. In this trial here, more sick patient, more severe ARDS, lower PO2 FiO2 ratio. We followed the ARDS guidelines. It's the lowest tidal volume, sorry about that. And that resulted in a better 90 days mortality, 23% versus 41%. These are some of the factors why this trial came back positive. ProZeva trial that suggested prone ventilation will be associated with better outcome. Two trials came out for high frequency oscillation, no significant improvement, and one of them, oscillate trial, actually may increase hospital mortality. So if you have a multiple choice question, don't use the high frequency oscillatory ventilator. Can be used in case-by-case basis, but generally you have to know prone position, improve outcome, and the high frequency did not. ARDS, you have to remember your ventilator, try to minimize everything, tidal volume, titrate the PEEP to prevent alveolar collapse, adjust your FiO2 ratio, prone positioning, rescue therapy in severe cases, including ECMO, nitric oxide, and such. And you can remember the formula for predicting the body weight. Usually here, if someone is 5'11", so you can use the 11, multiply the 11 by 2, add 50. So 11 by 2 is 22, 50, 77. That's a quick way to calculate your predicted body weight. And finally, BiPAP, you have to know the indication. The most proven indication is for COPD exacerbation complicated by hypercapnia and cardiogenic pulmonary edema. The evidence is stronger for these two indications. Also, there is evidence for post-operative and immunosuppressed patient, but the evidence is lower. Don't use BiPAP as a rescue therapy if you do extubation and the patient fails extubation. Just re-intubate the patient. Don't try BiPAP because that can be associated with a worse outcome. Also remember, you should have a good mental status, no facial injury. You don't have to have, you should have close monitoring. Don't put a patient on BiPAP and go and say, okay, I put the patient on BiPAP, he's doing fine. No, you have to be there, repeat a blood gas in 30 minutes and see if the patient is not doing well, you can change the setting, or if the mental status is worsening, you have to intubate that patient.